everybody. And I should probably say a very, very early good morning to Professor Doreraj, because I think it's nearing midnight or just crossing midnight in Florida. So let me start, of course, by welcoming our dynamic, innovative, always there for us, President of KSOS, Dr. Arup Chakrabarty. Arup, I know how busy you are. I know what a lot of commitments you would have on a Sunday morning. So it's been more than gracious of you to agree to inaugurate this oration and to be present here to deliver the inaugural address. A dynamic, there's some echo somewhere. Anyway, Gopal, equally dynamic and able help to the president and a future president of KSOS, I'm sure, our able General Secretary, and another very able person, Dr. Srini, Chairman, Scientific Committee. Welcome on this sunny morning in Calicut to our second in the series of orations and the second PG state level quiz. Prashod is busy elsewhere, I know, but will be joining. And I have to welcome him as our quizmaster, a very popular, very much sought after quizmaster. So it's been kind of him to take over the mantle of quizmaster again for our state level quiz. I welcome all the 6 teams representing 6 districts of Kerala. I welcome Dr. Doreraj. I saw him briefly. We will be welcoming him again when he joins. He's been burning the midnight oil for us. It's really, really tough, I know, making his time suit ours. Professor Doreraj from the Mayo Clinic in Jacksonville, Florida. I welcome you to our oration and look forward to hearing from you. And of course, all the participants, all the people who have joined us on YouTube, welcome. I'm sure it will be worth your while spending this morning with us. Welcome once more, everyone, and thank you. Back to Bindu.
Thank you, ma'am. Now I invite President KSOS, Dr. Arup sir, to inaugurate and give the inaugural address. Sir, with your permission, shall we go to the lamp lighting?
Of course, sure.
Over to you, sir, for the inaugural address.
Good morning, friends. Thank you, Padmaja Madam, Jyoti Madam, Bindu and Dr. Dalia for asking me to inaugurate this very important and interesting session. I'm the president of KSOS, Arup Chakrabarty, and a warm and hearty welcome to all of you, the viewers who are watching this marvelous program. I'd also like to thank our dynamic secretary, KSOS, Dr. Gopal, and the scientific committee chairman, Dr. Srini Odikulon, for making KSOS a very vibrant organization. It has been a very vibrant organization all along, and this year also we are not lagging behind. In fact, there we have been having a sort of, a festival of webinars. We have a webinar today in Trivandrum, a webinar, and followed by a oration lecture, followed by a CME program here today. So, things are really happening and people are really enjoying, all the viewers, very high quality programs. And I would like all the district associations and Dr. Srini to organize and make sure that such events are, are more frequent. The continuity is maintained throughout. KSOS also has been very active in the non-academic fronts. in addition to these webinars, the PG programs and other some similar journal clubs. For example, we have been having a session with the prominent ophthalmologist, senior ophthalmologist in Kerala, and using these educative material and for marketing about ophthalmic diseases, ophthalmic conditions among the public. So this is something we have started this month, and let us see how it goes. I hope we are really able to take this project forward for the Kerala public layman to understand more about ophthalmic issues, ophthalmic diseases and conditions. In addition to that, we have teams which are functioning, behind the screen for NABH accreditation. We'll be soon sending an email to you and WhatsApp messages to you for NABH accreditation issues, related issues. There is a team for infection control to look into how to prevent cluster infection. And if unfortunately there's an issue, then how to go about handling that. And we have many such, there's the instrument purchase assistance committee. Again, you're going to come live on the KSO's website for any person, any ophthalmologist wanting to purchase basic equipment related to ophthalmology. And so there are plethora of projects and a lot of things are happening. And I'd like to congratulate office bearers of KSOS for their active involvement in all the projects of KSOS. As regards today's guest oration, Dr. Cyril, I have known him for quite a long time. In fact, we have shared the podium in some glaucoma sessions at APO. If Cyril remembers, it was, I think, the APO in Hyderabad, 2013. And the year before that in Guangzhou. So he is an excellent orator. He has done a lot of original work in glaucoma, some landmark work. He has worked with some of these pioneering the giants in the field of glaucoma. So a warm welcome to you, Cyril, for this particular program. And that will be followed by the quiz. And Prashobh has been conducting the quiz for the last couple of occasions in a very, very professional manner. He has taken it at a high level. So I wish you all the best for the quiz program also. So a hearty welcome to all of you, and I wish this program all the best. Thank you very much.
Thank you, sir. You've always been very supportive and encouraging. Now I welcome Dr. Gopal to give the felicitation.
Thank you very much, and a warm good morning to you. Here there is light rain. There you said it is a sunny morning. So nice to see you all in a sunny morning there. So let me start by saying that Arup sir said that we are not lagging behind. But I think under his, he has been very kind to us. What I would like to say is under his able leadership and pushy nature, me and Srini has been working on, and according to his wishes only, we have been running all through these programs. So as sir told, we have a lot of programs, not just for ophthalmologists, but for non-ophthalmologists as well. And the last glaucoma week was no exception. We had a wonderful time when 150 eye hospitals came together to do glaucoma screening camps together on a same day. That was a real wonderful thing. So I do not wish to bore you with all the programs that we are going to have. So all the best to the Dr. M. Prabakaran sir oration and the quiz. Let the best participant win. All the best to you. Thank you very much.
Thank you, Dr. Gopal, for all the wishes. Now I invite Dr. Srini, Scientific Committee Chairman, for the felicitations.
Thank you, Bintu. Thank you, Padmaja ma'am, Jyoti ma'am, Dalia. Good morning to you all. Kozhikode Ophthalmic Society has been one of the real vibrant district ophthalmic societies. Previously, it used to be just TACO and COC dominating the scene, but Kozhikode is really catching up, and probably they have a chance to be the best ophthalmic club under Dr. Arup's leadership. And as Gopal said, Arup sir has been pushing us to be on time, to do programs, and always like we have our constructive arguments, but everything is we are all working towards making KSOs greater and greater. As Sir said, see, KSOs has always been a great organization. I mean, you compare all the district associations, this is the most vibrant one. No corruption, no nepotism, nothing here. It's just pure work by the office bearers for ophthalmologists in Kerala and ophthalmology in general. And we have been doing, Gopal has explained the different activities, and from scientific committee part, group part like me, Thomas George, Sujit and Prashok, we've been putting in our best. So we'll be having the 12 KSOI Scientific Committee CME series. The first, I thank Kozhikode to having started it at really with a bang. And anyway, I'm not prolonging my talk. All the best for Dr. M. Prabakaran Oration and the state level PG quiz. As Gopal said, let the best team win. Thank you once again.
Thank you, Dr. Srini. Now, as we move on to Dr. M. Prabakaran Oration Award, I invite Dr. Padmaja Madam, who was fortunate enough to be his student, to say a few words about him and to present the Oration Award.
Thank you so much, Bindu. Like you said, Dr. Prabakaran was my first teacher as I took my first baby steps in my career of becoming an ophthalmologist. None of us senior ophthalmologists of Calicut who were fortunate to know him, to be taught, to be mentored, and just to befriend him will ever forget the kind of person that he was. But as years go by and as numbers decline, it behoves me to present the man that we all knew and we can never forget. Dr. Prabakaran was born in Palghat in 1926. He did his early schooling in his own little village, then went to the Victoria College, Palghat for a BSc in chemistry, following which, he did a BSc in physics. I always make that mistake. And then he went on, decided he wanted to do medicine, moved to Madras Medical College in Chennai, completed his MBBS. And one of the things that he achieved at that time was a first class distinction for the first MBBS, which is no mean feat. Following that, he did a DOMS, spent some time in Lakshadweep, came back to Kerala, did an MS from Lucknow, and after that, came back to government service, joining first at Trivandrum, and then moving to Calicut, where he worked, taught, and lived for the rest of his days. What are the things that come to mind whenever I think of Prabakaran sir? I remember him as a very popular teacher. He had a loud, booming voice. He used to gather all of us junior postgraduates around him when he took his undergraduate classes. And it was a pleasure learning the very, very, very basic concepts that some of our PGs do not pick up because we take it for granted that they know them. Of course, those days, the knowledge was not as much, but Prabakaran sir taught us the very basic, just with a torch, what a lot of ocular pathology could be picked up. He was a gentleman to the core. There wasn't anything in him that resembled guile. He let his opinions be known loudly and clearly. And one of the things that I remember every time I think of Prabakaran sir is one of my last meetings with him when he was admitted to National Hospital. I was a teacher in my own right and an examiner by then. And I remember telling sir, it's so depressing teaching undergraduates these days. They simply don't care for ophthalmology. And they have no clue about, for them, the choroid and the conjunctiva seem the same. And he smiled and said, Padmaja, remember, in Kerala at least, none of these people will ever practice ophthalmology. For that, people will go only to the ophthalmologist. Why do you want to fail them and carry that burden with you? I would say be very, very liberal with the undergraduate. But if he comes back as a postgraduate, that's when you've got to make sure that he knows what he's doing. And then you fail him or pass him only purely on his own merit. Sir was therefore a very kind, considerate examiner who made every person who came and sat in front of him feel at ease, something that probably I'm not capable of. I often wonder whether I intimidate a candidate in front of me. So it is in the memory of this excellent teacher among teachers that the Kozhikode Ophthalmic Society last year instituted this series of lectures for postgraduates. And it has been our proud privilege, and we've honored ourselves by instituting this tribute in the memory of this great teacher. Sir died in 2011, and he left behind a huge vacuum in the hearts of all those who knew him, his family, his students, his colleagues, and of course, his large patient following. With these few words of reminiscences, I now move on to presenting the second Kozhikode Ophthalmic Society's Dr. M. Prabakaran Memorial Oration to Dr. Cyril, who, though I do not know personally, is Professor of Ophthalmology at the Mayo Clinic in Jacksonville, Tennessee. The citation that goes with the award reads, the Kozhikode Ophthalmic Society presents the second Professor M. Prabakaran Memorial Lecture Award for PGs to Dr. Cyril Dorairaj, Professor of Ophthalmology at the Mayo Clinic of Medicine and Science in Florida, the USA, in recognition of his outstanding contributions to the field of academics, research, and organizational activities. Presented this day, the 27th of March, 2022, on behalf of the Kozhikode Ophthalmic Society by Dr. Padmaja Krishnan, the President, and Dr. Bindu Ajit, Secretary of the Society. Thank you.
Thank you, ma'am.
Bindu, you're muted.
Okay. So it's a proud moment for us. So for the Dr. Prabakaran Oration Award and for his lecture, I invite Professor Cyril Dorairaj. Dr. Cyril Dorairaj is a professor of ophthalmology, Mayo College of Medicine and Science. He is a consultant in the Department of Ophthalmology, Mayo Clinic, Jacksonville, Florida, and is also a program director for the International Council of Ophthalmology, International Ophthalmology Fellowship Foundation, the Glaucoma Fellowship Program at Mayo Clinic, and he's got many achievement awards. He's a recipient of achievement awards from the American Academy of Ophthalmology and Asia Pacific Academy of Ophthalmology. And he is one of the pioneers of minimally invasive glaucoma surgery, and his extensive research on understanding the biomechanical aspects of glaucoma, especially in angle closure glaucoma. He's trained at the New York Eye and Ear Infirmary and New York, and diplomat of the American Board of Ophthalmology. He's a fellow of American College of Surgery. He has undergone international training as a clinician scientist at the Indian Institute of Science, Bangalore. As a fellow in ophthalmic molecular genetics, he has held positions of director of ultrasound biomicroscopy and anterior segment imaging and the director of clinical research at New York Eye Infirmary, New York, and is also the executive editor of the journal Clinical and Experimental Vision and Eye Research. And he is on the editorial board of the journal of the Current Ophthalmology Practice and Ophthalmology and Therapy. And he has been a peer reviewer for multiple international ophthalmic journals and extensive reviewer for multiple international bodies and committees, including Ministry of Health Malaysia and the Government of Hong Kong. He has mentored multiple international and national fellows who are working in the academic positions all around the globe. He has presented over 100 instruction courses and over 300 lectures worldwide, and has been an invited speaker and chaired session at national and international conferences. He has been the program chair at multiple international conferences, including the World Ophthalmology Congress, World Glaucoma Congress, World Glaucoma Association, and Asia Pacific Academy of Ophthalmology. He has co-authored over 200 peer-reviewed publications, abstracts, and over 50 book chapters and editorials, and a book on glaucoma management too. He has been an advisory board member for multiple industry partners, including Alcon, Iridex, and Allergan. And it's really a proud moment for us to have him. And he's the most humble person. And I've been fortunate enough because he was the one who mentored me to start the microinvasive glaucoma surgery in our institute. So presenting to you the youngest professor and the most he likes to be the first to do most of the things. And over to you, sir, for the oration lecture. I think he's not able to join. No?
Padmaja Madam said that he's already, is he the user one? Bindu, you're muted.
Actually, I sort of assumed that he was user one. We saw him joining and connecting to audio, but at that time it said Dr. Doreraj. And then somebody else also thought that user one was him. It's a very, very awkward time for him. It's past midnight.
No, just send the message in the morning, just 8:30.
Excuse me, who is user one?
And it must be some of the PG quiz participants.
Would user one identify themselves on the chat box, please?
Bindu, did you call, sir? Did you call Dr. Doreraj? You're calling. No, you're muted again.
Sir, can you just join in? It's already. Yeah. Okay.
Okay.
Just 9:15 I called him. Sir, can you start your presentation, sir?
Hello.
Yes, sir. We are. It's audible.
Okay.
Welcome, sir.
Oh, thank you. It's a pleasure. It's my pleasure. Thank you.
We are live.
Yeah. Sir, can you start your presentation, sir?
Okay. I just want to make sure you see my screen or one
Yes, sir.
second. You can. Okay, can see my. Okay.
No, your screen is not visible, Cyril.
Yeah. Just one second. I'm just going to make sure. You see the screen right now?
No.
No.
Yes, sir. Now we can see.
Yes.
No, I can see it. Okay.
We are seeing
Thank you.
all the attachments, not a PowerPoint though.
Okay. Are you seeing the PowerPoint now? Or
No, not yet.
not yet?
We are seeing the
Okay.
folder called Oration.
Oh,
The
okay.
content of those folders.
Maybe. I think I got it this time.
Mhm. Yes, sir.
Okay. Okay, Dr. Bindu, and it's what can I say? It's like 12:30 a.m. for me here.
Yeah.
Good morning to you all. And I'm very grateful for the invitation. I appreciate it. I see a lot of familiar faces there, but I wanted to take this opportunity to convey that basically we are made by our teachers. dedicated teachers, they lay the foundation for our education that makes us what we are today in the society. And we are better physicians because of them. Like Professor Prabakaran, they made us to be a better physician so that our patients have a better vision because of us. In a Sanskrit, they say that yata guru tata shishya. That means, we become our teachers. We kind of take legacy, a part of their legacy with us as we kind of go about taking care of our patients. But the most important thing that we need to do is to grow, to evolve on what they teach us. That's the most important thing. In my last 30 years of being in medicine, one of the most important things that I learned is about angle closure. So I believe in our lifetime, if there is a permanent blindness, if there is anything that we can change to be a preventable blindness, is angle closure. My understanding from starting from the diagnosis to the therapy of how we take care of this angle closure has completely changed over the last 30 years. Because what happens is early detection and timely intervention to take care of the angle closure most of the times prevent blindness in us. So one of the most important take-home message from this lecture is how to do an evaluation. So the accurate diagnosis of angle closure is done by doing an indentation gonioscopy. Indentation gonioscopy that has to be done in total darkness. So when I was a medical student back in 1990, when I was a surgery intern, when I was doing my house surgeonship, I used to have a book for surgery. It's called Bailey and Love. So that book, whenever I had that book, in the first page, it would show, it had a phrase. It said, if you don't put your finger in it, you put your foot in it. What it means is, whenever you have a patient with acute abdomen, it's important to do a parectal exam. So now with a lot of new things that's coming in, like a CAT scan and other things, we do a lot of things to evaluate an acute abdomen. But the most important part of our investigation is to do a parectal exam. In ophthalmology, exactly, to do a gonioscopy is very important, especially to evaluate a glaucoma patient. All patients, at least once a year, they need a gonioscopy. Because gonioscopy is not only just changing the diagnostic part of it, but it's also kind of changing how we use this in the therapy. I'm going to come in a few minutes about it. So if you actually look at the prevalence of angle closure worldwide, it's not a true reflection of all the publications that's out there. This is one of the letters that I wrote with the Yanev to the editor, showing that there is a huge discrepancy. Whatever we talk about, even in Caucasian patients, they say it is just less than 1%. Even in India, it's not equally represented. So I was talking to Dr. Bindu today, I was checking about the prevalence. Almost more than 50% of patients from India will have some sort of a mixed mechanism angle closure. So this is the main problem. It's many times, it's not only just how we diagnose angle closure. Many times we do a gonioscopy, but not really we know that what we are diagnosing. And it's also, there are countries where you hardly have a slit lamp. You don't even have a gonioscope. But there is countries where you have imaging for everything. So there is a huge discrepancy in the actual data that's been published so far to detect or to say this is the prevalence of angle closure. So when it comes to gonioscopy, the most important part of gonioscopy is to do an indentation gonioscopy. To do an indentation gonioscopy, there are various different types of gonioscopes that's available out there, but most commonly that has to be used is the Zeiss 4 mirror. It has to be less than the size of the cornea, where you can indent at the center, and then you can actually diagnose where exactly the blockade is, whether it's a relative pupillary block or it's a plateau iris or something else, even if there is a peripheral anterior syne cave, that's where you use an indentation gonioscopy to actually diagnose where exactly the blockade is. But if you actually see, if you use a 4 mirror or a 3 mirror Goldman, which is bigger than the size of the cornea, you're actually causing more angle closure in them. It doesn't actually predict the peripheral anterior synechiae properly in those patients. And it's also important that you need those testing in total darkness. You have to do the test in total darkness, indentation, and also like use the slit lamp beam off center towards the pupil so that you can actually detect angle closure more easily. So, but when it comes to like using other complements, like to detect where exactly the blockade is, this is where I learned quite a bit of evaluation of angle closure. If you see the chronology of events that starting from 1916 when Gullstrand introduced slit lamp until like 1992 when Chuck Pauline and Foster from Canada introduced the UBM. UBM became a major source for understanding of glaucoma. So like I was a UBM fellow, like I was an imaging fellow at New York Eye Infirmary when I started in 2003. And then I used to do 10 to 15 UBMs, almost like on all angle closure patients. There I understood the importance of evaluation to document it. UBM is like you take a snapshot that kind of like, even if when you show it to your patients to understand the pathology, it became an important contributor to not only just for the patient, even for us, for prognosis and follow-up of this angle closure patients. And starting 2000, anti-segment OCT was introduced, which used like 1310 nanometer light so that you can actually see the angle much more faster in a more physiological way. So this is the UBM P40 that I used to use. The eye frequency, it ranges from 50 to 100 megahertz, but most commonly it uses like 50 to 60 megahertz, and it has a resolution almost like 25 to 40 micron. But when you use the anti-segment OCT, the resolution is almost like 1 micron. It's almost like a microscope. You are taking cut section under a microscope. So based on the UBM and the imaging, you have 4 levels of angle closure. The most common is the relative pupillary block, where there is a convex iris configuration. Even if you take an eye from the eye bank and then take out the iris and put it in a petri dish, most commonly the iris goes like more convex like this. That's basically because that's how the smooth muscles in the iris makes the iris more convex and causes angle closure. And the next level is the plateau iris, where there is a large ciliary body, you see this, that's kind of pushing the peripheral iris more anterior and causing the angle closure. This is the next level of blockade. And of course, the lens related. This is more common. You don't see patients like this where you have a mature, hypermature Morganian kind of a cataract, like which is causing the blockade here. But you see subtle changes. If you draw a line between scleral spur from one to the other, and if you see the platform by which like the lens moves more anterior, you see more common this kind of angle closure. And of course, the 4th level is the aqueous misdirection. Though we used to call this as malignant glaucoma before, this is the aqueous misdirection where the ciliary body is like rotated. Even you can see the zonules are also rotated and kind of like seen most commonly in post-op in angle closure patients. So this is the summary of all 4 levels of angle closure. When it comes, and this is the anti-segment OCT, as I was talking about, using different light source right now, where you can take pictures, but one disadvantage here is you can't see structures below the iris because the pigment epithelium blocks the iris so that you can't see anything below. But if you want to actually see the structures more posteriorly, the newer versions are coming into market, but it's not at FDA approved, but you might have it soon. So like if I had to give you some tips, like even if you are using an UBM and an anterior segment OCT, the most important step is to do those imaging, or even the gonioscopy, as I was telling, is to evaluate under total darkness. This is one of the papers that I published very early in my career, where you actually see, like, you can detect more angle closure, almost like 60 to 80% of angle closures detected when you do the testing under total darkness. And even the quadrant that you analyze is different. If you know, like the superior quadrant is the most narrowest of all in the angle closure, because the superior angle, the root of the iris is much more smaller compared to the inferior nasal and temporal. So it's very important for us to evaluate the superior angle whenever you're trying to detect angle closure. And also the accommodation step. If you're trying to take a picture, especially make it consistently at the same time, like say like 10 seconds. Because what happens if the patient starts accommodating at a particular level, the iris starts moving up and it causes more angle closure. So you have to, like, if you're bringing the patient after some therapy or like even for follow-up, make sure you tell your technicians that you take a snapshot exactly at the same time every time they come. And also, of course, like if you're doing different technology, whether if you're using a UBM or an anti-segment OCT, now UBM can be done in a sitting posture. Like before 15, 20 years back, I used to do UBM and a total flat. Now, so all those things has to be considered whenever you bring these patients back for analysis. Again, like how you evaluate them, it should be consistently the same thing. So based on the gonioscopy and the imaging, gonioscopy basically, like American Academy of Ophthalmology came with different levels of classification for angle closure. But the most important thing is whether it's a suspect, primary angle closure suspect, where there is a more than 180 degrees iridotrabecular contact. That's oppositional closure is there. And angle closure is when there is a PAS, peripheral anterior synechiae, and increase in intraocular pressure. But when you call primary angle closure glaucoma, there should be a damage to the optic nerve. So 3 levels, PAS, CS is the suspect without damage to without peripheral anterior synechiae, no increase in intraocular pressure. Patients with PAC is like when there is actually an increase in intraocular pressure and then peripheral anterior synechiae, and glaucoma is when there is an optic neuropathy in these patients. So when it comes to management of these patients, most of the cases, how we treat them is, this is one of my patients, like I'm telling my patients that I'm going to do a surgery, basically do a laser or a surgery, but you have to understand that I'm not doing the surgery to improve your vision. So like the patient was like what? Why are you doing this surgery? How is it going to affect me? Because many of the times when we treat angle closure, it's a preventable condition that we are kind of like avoid blindness in these patients. And one of the most common way is doing a laser PI, either using an argon or an YAG. This is one of the most common ways by which we treat it. And if you look at the iris configuration before and after laser, if you see the convex iris configuration, once you do the LI or the LPI, in this patients, the iris configuration kind of becomes more concave after you do the peripheral iridotomy. This is one of the best ways to treat relative pupillary block. But there might be cases where there is plateau iris. Even in spite of doing a laser iridotomy, you still have a blockade when you do a dilation or like even total darkness. Those patients are because of plateau iris configuration. It's known as plateau iris syndrome, where there is a patent peripheral iridotomy and you see an angle closure in them. How do you manage? There are a lot of literature, there are controversial literature out there, but when I was trained, I was to do argon laser peripheral iridoroplasty in those patients, where basically what you do, this is the video, just wanted to share it with you, where you go to the periphery of the iris and you give almost like 24 to 30 burns towards the periphery of the iris. Argon laser is used, the size is almost like 500 microns. And you see the periphery of the iris is like squished like a bread, like it's squished and then it kind of pulls the periphery iris into the more center. So this is the argon laser iridoroplasty. We used to do quite a bit when I was under Dr. Rich at New York Eye Infirmary. So you see, once you do this laser, the periphery of the iris is pushed down and then it opens up the angles mechanically. You place almost like 24 to 30 burns in the periphery. And remember, you have a patent peripheral iridotomy in all these patients. Coming to studies, a lot of studies have come out that kind of affected how I take care of patients. There are 2 major studies that kind of like came in recently in last 3 to 4 years. One of the major studies is the ZAP study. Probably this was done as a collaborative study from Paul Foster, and it was done in China. It was done in China where they looked into almost like 12,000 patients with primary angle closure suspect. Suspect is when they had an angle closure, an oppositional angle closure, and they kind of like divided them into 2 groups. One had a laser iridotomy, the other eye didn't have the laser iridotomy. And then they looked into almost 6-7 years. 6-7 years, they followed up to see the other eye if they develop angle closure in them, PSC. What they noticed is the main conclusion is They didn't see that much of angle closure in patients who didn't have a laser iridotomy. And their conclusion, they said, we don't have to do widespread laser iridotomy. What's the take-home message from us? Can we actually do the same thing in our patient population? No, not exactly, because every patient is different. So what I do is I kind of like take it one step back. I'm not treating the angle. We are treating the patient. You have to check about the symptoms. You have to check about the family history, whether the patients are hypermetrope, and then whether the patients had any symptoms before. All these risk factors, even before, like if they have any retinal issues, the patients have to be dilated. If they have blood sugar issues or hypertension or anything that needs a retinal exam frequently. All these patients, when you consider them, you need to do a laser iridotomy. So this paper is like a little bit controversial, but my recommendation is just focus on your patient, not just the angle, and then try to take care of that. The next study that kind of like brought in was like a few years back is the EAGLE study. The importance of this EAGLE study is that it enrolled almost like 419 patients. And then they looked into two group of patients, primary angle closure and primary angle closure glaucoma patients. And then they evaluated the role of clear lens extraction in them. So they enrolled almost all patients more than 50. And then they looked into clear lens extraction. And their endpoints is not progression of glaucoma. Their endpoints is quality of life, the mean IOP, and the cost over time, or how it affected that. The importance is we never check all these things in our patient population, but this is what they looked into. And their main conclusion is, this is the questionnaire they gave. The main conclusion is almost after 3 years, patients who underwent clear lens extractions definitely had a better outcome compared to other ways of treating, whether you do an iridotomy or you're using a medication in them. Patients who had a clear lens extraction, the EAGLE study kind of like showed they had a benefit of it. What's my take-home point in it? It's like when I treat, I do probably like 10 to 15 surgeries a week, and predominantly patients with angle closure. So like my thinking is, but even if the patients doesn't have like 30, their cutoff is 30 millimeter of mercury, their age group was almost like 60, 65. But if you look at the Medicare data from United States, the average age of patients undergoing cataract surgery is 65. This study also had patients almost like around 60, 65. So I'm kind of like a little bit going towards again treating the patient, saying like you have angle closure, and then I offer them in case like if you want to take care by doing an iridotomy, or if I have to take care of angle closure, if they have a peripheral anterior synechia, I kind of like offer them to do a goniosynechialysis, and then other options like like goniotomy. I'm coming to that data a little bit later, and try to take care of this. So a simple laser, a simple surgical option, even a lens removal in patients can prevent permanent blindness in most of our angle closure patients. So I'm going to switch gears right now, and then going to go towards not just treating the angle closure glaucoma patients, but what's the importance of angle? What is the importance of angle? The role of evaluation of angle diagnostically, and how it's affected us in terms of therapy. So if you look at the chronology of surgical events, like what has happened starting from 1856, when Van Graaf introduced the iridectomy, to like earlier in 1936, when Prabakaran introduced goniotomy, until 2004, we had the trabectomy. That is the first introduction of a MIGS, an angle-based surgery that was geared towards open angle glaucoma. So if you look at all the surgery, this is the goniotomy. If I have to ask you a question, what is the most effective, minimally invasive surgery that you have done on one of the most severe glaucoma is this. That's what you're saying, the goniotomy. All you do is using an MVR blade, you're cutting the membrane, whatever the Prabakaran membrane that we speak about, you're just opening it up, and patients like children have one of the best outcomes. Unfortunately, this was again repeated in adult patients in 1980s. Dunbar Hoskins actually did a thesis in AOS, And then he kind of like looked into doing a goniotomy, something like very similar, like a minimally invasive surgery, but unfortunately it didn't work. They caused more scarring and then patients had problems. So that is why they didn't do this. But now, starting from 2004, more and more minimally invasive glaucoma surgeries have been introduced. Now, at an average, this is my Friday. This is my, like this week, this Friday, I just took out all the instruments in my office and I took a picture of it. I do almost like 12 to 15 different surgeries for open angle. So all this surgery, like all these devices that's been like KDB Glide, and there is 4 series of eye stands, and like all these things that's been there, like, you know, this is all introduced for open angle glaucoma by FDA. And there's 3 more devices that's coming in another 3 months. So where are we right now? So the importance of angle has completely changed because all this angle-based surgery is going to be done not by glaucoma specialists, but by a comprehensive specialist, a cataract surgeon, a cornea surgeon. Everybody is going to do this. So that is why the importance of gonioscopy. I know this is a general population that I'm focusing on. You don't have to be a glaucoma specialist to carry your gonioscope. But even if you're doing a cataract surgery and if you're going to take care of mild to moderate glaucoma patients, it's important you evaluate the angle. Because even in the United States, we do almost like 4 million cataract surgeries, out of which 20% of them, almost 1 million of them have glaucoma, mild to moderate glaucoma. And it is taken care by doing some sort of mix. The goal is not only just to stop the progression of glaucoma, the goal is also to reduce the burden of medications and stabilize the glaucoma in the long run. So this is what's happening. So if you see some of the data that's coming out, looking at the Medicare beneficiaries, it's not the previous surgeries that we typically would do, like, you know, trabeculectomy, glaucoma drainage device that we would typically do in a severe glaucoma patients. We are doing more and more minimally invasive glaucoma procedures. And if you see that number, almost there is 426% increase. It's not 1 or 2, 426% increase in the mix, and predominantly done by cataract and comprehensive surgeons. It's not the glaucoma surgeons. So they give it to you. So what's happening is, unfortunately, this is what happened a few years back. What we noticed is, you know, this is from the AGS network, what they said, like, we don't know which patient. I showed you so many devices. We really don't know where exactly, which patient needs what. So that's why we are all confused. So that's why it becomes more and more. It's almost like cardiology. We are going into that phase where we have to image, we have to do a proper gonioscopy and then evaluate where exactly the blockade is. Probably that would be the future where we'll be doing all this thing together. Because this is one of my patients where a stent was placed, and you see this was done by a cataract surgeon. But unfortunately, the patients, after the cataract surgery, the pressures went up to like 30s and on 3 meds. And if you see, it's not properly placed. This is where we are going. So like, I know like last year, iStent was introduced, and more surgeons are going to offer it to their patients. And more devices and procedures are going to be based on angle surgeries are going to be introduced in India. So get ready. So, but most important part is to be prepared. How do you prepare yourself to have the best outcome? Because all these devices that I showed, if you see it, is to be done in this 500 microns. The angle starting from the scleral spur to the Schwalbe's lane is almost like 500 microns. And then most of the structures that you're targeting is the pigmented trabecular meshwork. It's not the non-pigmented. It's the pigmented trabecular meshwork. Just behind it is the Schwalbe's. Below is the, and then behind is the Schrem's canal. That's where most of the procedures that you are targeting, all these devices, you do it. You won't have a best outcome. You won't have a predictive best outcomes if you don't do this surgery precisely. So whenever you do all this, you need to be very precise to have the best predictive outcomes and also the safety. So how are you going to optimize it? Right now, this is what like I would teach my fellows. I would teach my residents, you know, like learn to take your gonioscope, not just only in the office. If you ask me, what is the most common device that I use in my office or even in my day-to-day practice, is the gonioscope. It's not only just in the office, it's also like I take it to the operating room, though it's a very different view, but this is where like you have to like relearn, to understand, because it's a totally different dynamics when you are taking the gonioscope into the operating room and evaluating the angle. So first, all these patients that you are going to do any kind of surgery, angle-based surgery, make sure that you do a gonioscopy in the office. And if you want to document, take a picture, do any kind of anti-segment OCT or a UBM, and then go ahead and evaluate, take the gonioscope back, a different gonioscope into the operating room. There are a lot of gonioprisms right now. Pick one of them. And even before you actually do the surgery, you have to like learn how to do this on your regular patients. It's very important. There's like you have to learn, you go prepared before you actually start doing these devices. So most important thing is two things. One is the patient itself. The patient, you have to move the patient away from you when you're lying. Most of the surgeries are done in the temporal. I know some surgeons sit superiorly there, but I sit temporal and then move the patient away from you like 30 to 40 degrees. And the next thing is you have to move the microscope 30 to 40 degrees and then lift up the eyepiece. And then you have a better view. And then there are different views. Like this is from our Academy of Ophthalmology textbook. Like we have a series where it shows two types of views. One is kind of like a dive bomber view. Other is called like a cruise missile view. What basically is, if you are doing any kind of like a device, if the pupil is like constricted, you go straight parallel to the trabecular meshwork, the pigmented trap, where exactly behind is the Schemm's canal. But if you're doing a procedure after cataract surgery, when the pupil is dilated, it's more convex, then you go behind the dilated pupil. So there are different views, but what is more important is how you place the incision. You know, like when you place the incision, most of the time, if you go more scleral, you see that blood. You know, the most important part of any surgery is the visibility of the structures. Because if you don't have a proper visibility, like you're not going to have you're not going to cut the right things. You're not going to place the device at the right place. So you see, this is one of my colleagues, which I did a collaborative work. This is from Vietnam. I taught her how to do goniotomy over over Skype actually. And then she's trying to do this. And if you see, she placed the incisions a little bit behind and the blood is kind of like clogging everything in the front. So what you basically do is like you place the incisions a little bit anterior in the cornea just to avoid any blood on the cornea. And the other point is the blood in the trabecular meshwork. It's basically what's happening is when there is an hypotony that's induced, it causes some bleeding from the trabecular meshwork. So like whenever you have a visibility like this, you are not going to do any kind of procedure. Stop, step back, use some viscoelastics, and then make sure you have a proper visibility of the angle before you do any kind of surgery. So why does it happen? Like I was just explaining to you, it induces hypotony, and then the blood kind of like refluxes into the Schemm's canal. And then the moment you make a cut or the moment you place a device, it's going to reflex. But make sure the blood is stopped before. And also like you have to identify the structures properly. Because if you see like a sampolysis line or a peripheral anterior synechiae, make sure you release it, you identify whether this is a sampolysis line or it's a trabecular meshwork. You're not going to place a device on the sampolysis line because like you have to be very precise in detecting the trabecular meshwork before you do this. But when you have a peripheral anterior synechiae, the best way to push this down is to do a soft shell technique. What I typically do is I use a OVD, viscoelastic, and then push it at the periphery. So the iris falls down, you can see the peripheral anterior synechiae much more clearly in those patients. There's a lot of nuances in this. Like, when you do this surgery, like you're trying to do something good for your patients, but unfortunately, you have to remember not all surgeries will have the best outcome if you don't have the, doing the surgery in the precise tissue. So, and also like before you actually do any kind of procedures, try to mimic it. try to mimic it. I'm just using a Sinskey hook here just to show like how we go about doing the same procedure inside. So you, before, like you're actually doing a surgery, do all these things and then be prepared and then go about doing all this mixed procedure. This is the trabectome. I'm just going to like touch base on like what 3 or 4. This is actually the first to be introduced here in the United States, where the trabecular meshwork was actually ablated. I think right now, India, we have the first generation eye stent that's been introduced. Right now, here, like we are almost like starting a study of almost like the 4th generation. Like there are a lot of different things that you're going to be exposed to very soon. Just be prepared for it. And this is the goniotomy that's with the KDB. And you basically what we are trying to do here is not ablating the trabecular meshwork. We are just trying to excise ab internal trabecular meshwork excision. You just focus just only on the trabecular meshwork. You're trying to take out the inner wall, and then you kind of like give access to the Schemm's canal so that the distal collector channels kind of opens up and the fluid drains out more easily. This is the goniotomy. So of course, like I'm not sure if you have the Zen introduced. This is like was actually FDA approved it for to be done in ab internal technique. You go into the little bit anterior to the trabecular meshwork and then you place it. Now, like it's widely done ab external too, but it's basically approved to be done ab internal. So I'm very sure like you are going to see and you're going to use all these instruments and devices in your practice. So what is important for us is it's important that like there's no perfect surgery. There are always potential complications. That's all like we have to be prepared for. You have to prepare your patients. Sometimes you're like right now we are doing, premium lenses, or like you're doing a cataract surgery and the patient asks like, oh, can I go golf tomorrow? Patients, if they have a little bit of bleeding, a little bit of corneal edema, they can't. So it's, these patients, when you're targeting mild to moderate patients, I would be very focused to have a precise outcomes. You have to be very precise in doing the surgeries. Even when you're doing a goniotomy, if you go a little bit anterior, if you cut the decimae, you see the corneal edema towards the left side. And if you go more posterior, you're going to cause a cleft. These are all published out there. So use both gonioscopy, not only just before, but also after. If you see blood like this, and also use imaging, any kind of imaging. Immediately after the surgery, you can't use an UBM. Of course, that's why that I say that use an anti-segment OCT in those patients, and then you can document where exactly the problem is. This is one of the paper from Kaveh Mansouri from Switzerland, who actually looked into the surgeons doing the eye stent. This is eye stent inject. The goal is to place it in the Schemm's canal. And if you look at almost like 25 to 30% of the times, we are not exactly placing it in the Schemm's canal. It's like a 350 micron tube. Many times the pathology because of the angle, because of the glaucoma itself will affect it. So you won't have the best outcomes, if you don't place it in the Schemm's canal. So I'm going to leave you with one of the most important studies that I did, because my talk is all about angle closure. So like I did a combined, a study with a collaborative work from Dr. Tam from Vietnam. So what we did is basically because like I was talking to Dr. Bindu, like she said, almost 60 to 70% of our patients are angle closure. You're not going to have a typical open angle patient where you can do all these procedures. You will have peripheral anterior synechiae or all these patients. This study was done for almost like 42 eyes, severe glaucoma, ICD-10 classification. Most of them had very high pressures and also like visual field defects and almost like central defects. And we kind of like did a pre-UBM and post-UBM and then looked into the IOP. And we followed up for almost like 2 years. These are all papers, 6 months, 1 year, and then 2-year study that we looked into. One of the most important conclusion is like when we actually, this is the procedure. We did 2 steps. Because all this, you need to look at the angle. In this patient, if this is from Clementam, what we typically are doing is we are trying to lyse this synechiae. We are trying to open up the synechiae. And then the next step is to do the goniotomy. So 2 steps for angle closure glaucoma patients. So like almost like 42 eyes in both my patient population and then patients from Vietnam, both were analyzed for over 2 years. And this is my video, like where it's showing, I'm trying to release the synechiae, and that's the first step. And the second step is to actually do the goniotomy. You have to be very careful in this patients because of the synechiae. If you don't know where exactly you're going, sometimes you can cause a cleft, or you can cause more bleeding, iododialysis and other things. So use extra viscoat and just be careful when the tissue that you're cutting is almost same. Sometimes you can use pilocarpine post-op to keep. And this is the UBM pictures and also the gonioscopy pictures that you see. Like what typically happens is you're actually like creating more space. You're creating an extra angle out there. That's kind of like causes the root of the iris to prolong so that these patients have less risk. But though you remember this, it's already a sticky iris that you're opening up. And so like there is a very high risk because you're already causing more inflammation. It can come back and close it. The very fact is you're combining with a cataract surgery and you're creating more room for it so that the root of the iris falls out and you can put them on pilocarpine for the first few weeks, 4 weeks. This kind of helps keep the iris away from the trabecular meshwork in the beginning, and the steroids kind of helps stabilize them. And what we noticed is over time, over 2 years, the synechiae doesn't close. And because like you're also creating a goniotomy, it's not just only the synechiae, it's also we are creating a goniotomy. After we published it, a lot of papers came out, which we did the same thing. And they noticed that this is a very helpful procedure. The main conclusion is like you can offer this to our patients. And almost all 42 eyes that we did, none of them needed a second procedure after that. That's impressive. But you're still looking out for almost like 5 years right now. For treating angle closure surgically, this is one of the important steps that I would recommend. So what is the future consideration? The way that we are going in, we have to use both gonioscopy and any kind of imaging that's available for you to integrate both together and then do pre-op evaluation. And then in case if you have access to intersegment OCT mounted on your microscope, use it to focus your surgery to exact precise tissue wherever you are trying to access. And that will definitely help to have a best outcomes on our patient. It's minimally invasive because like there are a lot of papers that came in recently, like I was talking about, in American Glaucoma Society, all surgeons were asked 10 years back that, if you have a patient with severe glaucoma, what is the most common surgery that you will do? 10 years back, they said trabeculectomy or a glaucoma drainage device. Now, recently, 3-4 years back, they sent one more survey that got published in Journal of Glaucoma asking, say, if you are the patient and if you have severe glaucoma, what's the most common surgery that you would do, whether you would do a trab or if you're going to do a tube or anything. And most of them, almost more than predominantly, the younger surgeons prefer minimally invasive glaucoma surgery. So our glaucoma surgery is nothing but a balance of 2 things, is safety and efficacy. We sometimes, to have a more safer option, we kind of like compromising on the efficacy. Mix is something like that. Mix will have the best outcomes if you can have precisely targeting the tissue where exactly you're placing the stents or where exactly you're cutting the tissue, then it will have a very precise predictive outcomes. So that is why you don't have to compromise on the efficacy. Safety is predominantly the main factor. So the new thing is, the key is, when I was, if I remember 1990s, when I was a PG, I used to have 2 things in my pocket in my white coat. I used to have a pen torch or a torchlight, and then I would have a direct ophthalmoscope. Now, it's important that we take the gonioscope also with us. And like when I did a residency here, like we would have all the lenses with us. So that's what my take-home message for all the postgraduates and residents, fellows out there. The gonioscope is coming back. It's not just only in your office. You're going to use this more often, even in your operating room. not only, it's the key. It will be the master key to understand the angle. And then we'll be doing a lot of different new surgeries. The way it has changed my practice since last 15 years here, I predict this will happen there too for you people. And to have the best outcomes, to be prepared, start with the gonioscope. Thank you. Thank you. I know it's almost like 1 o'clock. I appreciate you giving me a chance to talk, and then in memory of Dr. Prabakaran. Thank you.
Thank you, sir, for taking us through the presentation, the pathology of angle closure glaucoma, and how the future in glaucoma surgery is going to change, backed with the evidence too. Thank you, sir. And the importance of gonioscopy, which we definitely will take home message, sir. And just a few doubts, sir. For the goniosyne, the thought was in angle closure, these gonio surgeries were doubtful, but you showed that it is possible. So for the goniosynovial lysis, I saw just a needle. Is it a needle, bent needle, or any other instrument you're using, sir?
The first video that I showed was the 26 gauge bent needle. That was from China. Clement Tam actually did this. The second part is actually using a KDB. The KDB blade was used for both goniosynovial and also goniotomy. Because most of the instances where there is a S-shaped angle closure, where the peripheral iris comes and then attaches to the trabecular meshwork, you still have a potential space in between. You just have to hook it in between and then pull it towards the centripetal, applying centripetal force towards the center. Thereby, you are lysing the synechiae and then releasing it away, and then use extra visco to push it down. And then the second step is to using the same KDB blade to do the goniotomy. So the first one is the 26 gauge bent needle that you saw. The second one is actually, that's the technique that we used for those studies, where the KDB blade.
Actually, after your guidance from you, when I've started using the 26 gauge needle, I want other people also to start it, which is easily available and can be practiced in our part of the country, where the other instruments are costlier.
I agree. I totally agree. It's basically how you improvise. I remember how we used just the air to do a capsular rhexis. We would just inject an air bubble. We would just use a 26 gauge needle to do a rhexis. At the end, we would just use a spirit lamp, and we'll have a ball cautery, and we would just close the conch with the ball cautery. We improvised. That's what, wherever there is resources, we use it. If it's not, we will just improvise with what we are left with, what we are given.
Yes. Actually, it was a really very illustrative, all the basic steps for all of them to start doing intraop gonioscopy and shift to MIGs.
Thank you.
And sorry for keeping you so late, sir. Thank you. We appreciate it so well, sir.
No, it's my pleasure. It's thank you. I'm very, hopefully, one of these days I would come and be there in person.
Yeah, definitely we would
be part of this.
Thank you.
Thank you,
madam.
Thank you so much, Dr. Cyril. I don't know how to express my gratitude for you sitting up, burning the midnight oil on behalf of all of us. I hear you normally go to bed early and wake up early. We've changed that for you this weekend.
No, it's a pleasure.
And certainly, we look forward to hosting you another time at a time which is much more congenial to you. Thank you. Don't know whether to say good day, good night, or good morning.
Yeah, it's a good morning, rather. Thank you. Thank you.
Thank you, sir. Thank you.
Thank you. Thank you, Dr.
Now we move on to our next session, the much-awaited quiz led by Dr. Prashobh. Over to you, Prashobh. We have the quiz master as Prashobh, and we have the scorers as Dr. Anju, Dr. Reshmi, and Dr. Farzana. We have the quiz master as Prashobh, and we have the scorers as Dr. Anju, Dr. Reshmi, and Dr. Farzana.
Hello, can you hear me?
Yeah.
Yeah, are we on air now?
Yes.
Thank you, ma'am. Thank you, Society, for inviting me to become the quiz master of the program. The quiz is actually we have scheduled it at 11.
Ashok, you're having
Your
network
video is
issues.
paused.
Other teams join.
Yes.
Team Kochi, Kozhikode, Thrissur.
One team is left to join.
Trivandrum is having some connectivity issues. They'll join now.
I think by that time we can ask the teams to introduce themselves.
Yes, that would be a good idea.
Yeah.
The teams introduce themselves.
Can start with Kozhikode.
Good morning, sir. I'm Ashwati from Comtest Hospital.
I'm Shahija from Medical College Kozhikode.
Okay, Team Kotem. I think you have to unmute. Kotem, can others hear?
No.
Team Kotem?
Madam?
Yeah, now you're audible.
Okay. Good morning, madam and sir. I am Dr. Ashwati from Kottayam Medical College.
I am Dr. Vishnu Gopal from Cotton Medical College.
Okay, welcome. Team Thrissur?
Good morning all. I am Dr. Lakshmi from Government Medical College Thrissur.
I am Dr. Emin from Government Medical College Thrissur.
Team Kochi?
Good morning. I am Dr. Maya from Little Flower Hospital, Angamali.
Good morning. I am Dr. Praveena Shyam from Amrita Institute of Medical Science.
Team Malappuram?
Good morning. I am Dr. Grishma from MES Medical College.
Good morning. My name is Dr. Anu from MES Medical College.
I think we have Trivandrum team yet to join.
Trivandrum's just joined, Bindu.
Yeah, Team Trivandrum, can you introduce yourself?
Good morning, ma'am. I'm Dr. Meru Agustin, final year resident at Chaitanya Eye Hospital and Research Institute, Trivandrum. I'm Dr. Shino Muralidharan, again primary resident, post-year resident, final year, Chaitanya, Trivandrum.
So Prashop, I think all of them have joined.
Hello, and nice to see you all. And I hope you have a good time connecting this way. We are a little early. I hope that's not a problem for you. I think we will start with choosing the order of your teams. There will be 6 teams in the beginning. So you will be named team A to F, and I will open a PowerPoint presentation now where you will get to choose one box. You have to choose one box. We will start with, I think, Team Kozhikode first. Please hold on. All right. You have 6 boxes here, Team Kozhikode. You can choose one box.
Box 3, sir.
Can you be louder, please?
Box 3, sir.
Box 3. So, Team Kozhikode, you are Team A. And now, Team Malappuram, you can choose. Please remember your team names, okay? You are Team
Box
A.
1.
Malappuram wants box 1. I hope our scorers, Dr. Farzana and Dr. Anju there and Dr. Rashmi, they're noting down which team is what. So Team Kozhikode is team A and Team Malappuram is Team D. You are Team D. Vandram?
Box 4, sir.
Box 4. Team Trivandrum is Team F. Team Kottayam?
Box 5, sir.
Box 5. Kottayam is Team B. Team Thrissur?
Box 2.
Box 2. Team Thrissur is Team E. And of course, Kochi is left with only one box and you are Team C. So I hope you all have understood your team names and our scorers are okay with it. Farzana, can you give me a thumbs up if you are okay with it? Farzana, Anju? You noted it down?
Yeah, for the ease of marking, it would be better if the teams can include the team names in the visible name IDs.
All right. So, start with our introduction. So, the KOS state level quiz competition has been going on for some time. I've had the opportunity to host for the past 2-3 years, and the level of competition has been quite high, and participants have been quite enthusiastic. So have been the organizers. And I would love to tell the audience as well that they have a few questions as well in this quiz. So please don't switch off. You may get a few questions in between. This is our team that is conducting the quiz. Myself, I'm Dr. Prashov. I'm your quiz master. Dr. Farzana, who is a customer officer at GMC Kozhikode, and Dr. Anju, who is a consultant plastic surgeon at Comtrust Kozhikode, and Dr. Rashmi, who's from GMC Kozhikode. I couldn't include her picture here because she joined a little late. But please accept my apologies, Dr. Rashmi. Our team will be conducting the quiz today, and I hope you're all geared up. All the teams are ready. Scorers, timers ready. Can the teams in their Zoom name, can you include your team name also in that? Trivandrum has done that, Team F. Kochi has done it. Can Kottayam rename themselves along with their team name as well? Be easier for the scorers. So meanwhile, I'll just go through the general rules. The rules are that both members of the team must be present at the same location, and please abide by the spirit of quizzing. I hope you don't use any Google or any other external help. And of course, we won't be responsible for any technical issues. And my decision is the final one. Even if I'm wrong, I'm right. And we'll have 7 rounds of quizzing in total. After the first 2 rounds, we will unfortunately have to let go of 2 teams, and the rest 4 will continue for the other rounds. We are going to follow the format called infinite bounds, where there is no direct and past questions. All questions are direct and have the same number of points. And teams must also have another device which should be used as can be used as a buzzer and also for the rapid fire round. Teams have been informed of this beforehand. These are the general rules. With that, if you are ready to go, let's go to round 1. Are you ready?
Yes.
All right. We're going to round 1. And you'll be using the infinite bounds method for this. And there's 10 points for the right answer, both direct and pass, and there are no negative marks. And we'll be going from team A to team F for this round. So team A, here comes your question. Please name this instrument. You have about 30 seconds to answer. There are no negative marks.
Sir, IOP for IOP measurement.
The question is simple. Name the instrument. Sorry, that's not the correct answer. Go to team B. Team B, please.
Pass, sir.
Team B has passed. Team C,
Lensometer, sir.
can you be louder?
Lensometer.
That's not the right answer.
Oximeter.
Team D,
Pressure gauge.
please be loud and clear.
Pressure gauge.
Pressure,
Pressure gauge.
that is not a pressure gauge. Team E,
Pass.
okay, team E has, please, I request you to attempt something. There are no negative marks. Okay? Always try and attempt. You never know how lucky you are.
Measure tensile strength.
No. Team F,
Refining of cylindrical part.
the question is name the instrument, not its purpose.
Pass.
All right. So no team has answered this. The answer is it's the Geneva lens measure. It is used to measure the curvature of the lens. An optometric instrument that is used to measure the anti-curvature of the lens. All right. So no team has answered. This question goes back to team A. The next question is again back to team A. No marks for anyone. Team A, you have to describe the image formed by this lens. You have to describe the image that is formed by this lens. You would have seen this lens quite commonly on your slit lamps. Mostly unused. Take a guess. There's no negative marks.
Really inverted.
Real?
Really inverted image.
No, that is not the right answer. Team B.
Virtual inverted and
Virtual.
magnified.
Virtual.
Inverted and magnified.
No, that is not the right answer. Team C.
The ruby lens, virtual and erect image.
I need the full description of image.
The virtual, erect, and minified image.
That is the right answer. This is a ruby lens. It is a concave lens and it produces a virtual, erect, and minified image at all distances. Concave lenses always produce virtual, erect, and diminished images. The ruby lens is used to see the fundus, mainly for optic disc examination, not commonly used nowadays. But that is the right answer. Team C gets 10 points. So the next question by the infinite bounds method goes to team D. Team D, are you ready?
Yes, sir.
This is your question. 10-year-old boy has left exotropia with lens amblyopia in the deviated eye, the vision of CF 1 meter. What test can be used to quantify the amount of strabismus? Please note, what test can be used to quantify the amount of strabismus? Team D. I hope the question is clear.
Yes.
D for dog, delta, not B.
Sir, team D, sir.
D, yes, Malappuram.
So prism bar cover test.
Prism bar cover test. That is not the right answer. Team E.
Modified.
Please be louder into the microphone.
Modified Krimsky.
That is right. That is the right answer. It's a Krimsky's test, or the modified Krimsky test that can be used. So team E gets 10 marks here. 10 points to team E. I would request you to rename yourself as team, or rename, or just add your team name along with your team. Yes, who has done it now. Anybody else can also do it. Any of the admins can also do it. So team E gets 10 points. So the next question is the right answer is the Krimsky's test, because you cannot use the alternate cover test because one eye does not have fixation. You need fixation is an important criteria to do an alternate cover test or a cover test. The next question goes to team F. Team F, are you ready? This is your question. What is the interpretation of a positive FDDT, negative Jones-1 test, and positive Jones-2 test? FDDT stands for fluorescein dye disappearance test. Team F.
Atonic sac.
Atonic sac. I'll give it to you. Can also mean another.
Lacrimal pump failure. Lacrimal pump failure.
Yes. What else can it be? To explain what it is. No, you have the marks. You get the 10 marks.
Is the lacrimal apparatus, the drainage apparatus is patent, but the pump is defective. So
yeah, can you explain how you get a positive FDDT in that? It's all right. So basically, the fluorescein does not disappear in 5 minutes. You get a lot of fluorescein left in the conjunctival sac after 5 minutes. Negative Jones-1 test means that the fluorescein does not appear in the blood jet that is placed inside the nostril, inside the nose. However, when you do a syringing, you get a positive Jones-2 test. That is, you have fluorescein within the blood jet. So this can be seen in two conditions. One is a partial obstruction of an nasolacrimal passage, and the other is the functional obstruction, that is a lacrimal pump failure. Team F gets 10 points. The next question goes to team A. Team A, this is your question. Patient has anisocoria that is greater in darkness. The affected pupil dilates with 1% apraclonidine and also with 1% phenylephrine. What does the patient have? Please be very specific with your answer. I'm not looking for a general answer.
Horner syndrome.
Again, I said I'm not looking for a general answer. Be very specific. There is a reason why apraclonidine was used. There's a reason why phenylephrine was used.
Postganglionic.
Can you be louder?
Postganglionic. Horner syndrome.
Horner syndrome. That is the right answer. It's a postganglionic Horner syndrome, where you get adrenergic supersensitivity. The apraclonidine is used to diagnose Horner syndrome, and phenylephrine is used to diagnose adrenergic supersensitivity, which is seen in the postganglionic Horner syndrome. That is correct. And team A gets 10 points. So now to team B. This is your question, team B. What is visuoscopy? What do you mean by visuoscopy? $30 to answer it. Timer, please tell me when the time is over.
Time over.
Yes, now moving on to team C. Team C is what?
Instrument for eccentric fixation in
Okay.
amblyopical.
How do you do that?
Sir, based on fundus evaluation, sir.
With what?
Um,
How do you perform visioscopy?
Sir, we look at the orientation of the fovea with using a direct ophthalmoscope, sir.
Direct ophthalmoscope. Anything special in the direct ophthalmoscope that you'd like to use?
So that measurement.
There is a reticule within the direct ophthalmoscope that you use, and it's used to diagnose.
Eccentric fixation.
That is absolutely correct. Team C gets 10 points. It is a usage of direct ophthalmoscope with the reticule to identify eccentric fixation. Team C gets 10 points there. So we have come to the end of the first round and don't have the scores just yet. I think we'll move on to the next round. And again, the rules are the same. However, we'll be moving in the reverse direction. Team F will be getting the first question. Team F, here is your question. Identify the instrument. Team F. Team F, Trivandrum, identify the instrument.
Pass, sir.
Pass. So we'll be moving on to Team E. Team E, your turn now.
Pass, sir.
Team D. There's no harm in being wrong. You can guess. Team D. D, no answer.
Hydrometer.
It's not a hygrometer. Team C.
There is an
Exophthalmometer.
It is a?
Exophthalmometer.
No, that is not the right answer. Team B. Team B, Kottayam. Guesses? No. Team A. Team A.
For evaluation of dry eye.
What do you think it is for? The name of the instrument. Anyway, that is not the right answer. Any guesses from any team? No points for anyone. The answer, it is a fornix depth measurer. It is used to measure the depths of the fornices. Important in cicatrizing conjunctival diseases such as ocular cicatrization, pemphigoid, or Stevens-Johnson. All right, so no team gets any marks. So the question goes back to Team F. Team F, your question is this. Name the sign. Team F. Radiographic question.
Well, it's optic nerve, sir.
Question is quite clear. Name the sign. It's not the right answer. Team E. The sign with a name. Team E.
Optic nerve evolution.
That is what Team F said. That's not the right answer. Team D. the name sign.
Street sign.
Can you be louder?
Street sign.
That is not the right answer. Team C,
The tram track sign.
can you be louder again?
Tram track sign, sir. Optic nerve
Seen
sheath.
it? That is absolutely the right answer. Team C gets 10 points. The tram track sign seen in optic nerve sheath meningioma. 10 points to Team C. Team B gets the next question. Team B, Kotte. Diagnose. Obviously, one is a clinical picture. The other two, you have to identify what investigation they are. And you have to give the diagnosis.
Dargasosis.
That is absolutely the right answer. Can you explain why you got that answer? You get 10 points. Okay.
That
I think you have an internet connectivity issue there. I can't hear you. But anyway, the correct answer is Stargardt's sign, Stargardt's disease, and you get 10 points. This is a clinical picture showing deposits at the area of macula. This is the fundus autofluorescence. And this is the silent choroid seen in FFA. Stargardt's disease is the right answer. The next 10 points to Team B, and the next question goes to Team A. Now look at these 4 pictures carefully, and there is a common thing that is abnormal in all these 4 eyes. A very disturbing thing to find when you get such a patient, but it is something that is being wrongly done. You have to identify what it is.
Sir, ACIOL. I didn't see
Implanting an ACIOL wrong?
No, sir. I read. Iris sharp. It's in the iridotomy.
Iridotomy?
Position is wrong.
Iridotomy position is wrong. That is not the right answer. Team F.
Flipped ACIOL.
Can you explain?
So the angulation is it's supposed to be it is supposed to be protruding anteriorly, but here it is projecting posteriorly, blocking the pupil.
How do you know from this 2-dimensional image it is anteriorly?
Haptic, by the orientation of the haptic.
Can you explain that?
No, it should be the other way. Like the leading haptic, the part which is closest to the ankle should be like should face us. The leading haptic.
Okay, you are right. The answer is correct. I'll give you the 10 points. Trailing haptic should be on the left-hand side of the surgeon while implanting the ACIO. This is a common mistake that is made many times by postgraduates, and the ACIO has to vault anteriorly. Not just by postgraduates, but by many surgeons, because the ACIO is usually packed the opposite way, the wrong way. You just insert the ACIO as the way it is packed, it can lead to a lot of complications. It can lead to a pseudophakic bullous keratopathy, glaucoma, etc. So here, you can see the trailing haptic is always, in all these cases, is pointing to the right side of the surgeon. However, it should be the other way around. The trailing optic haptic junction should be on to the left side of the operating surgeon. Get 10 points, Team F. Next question goes to Team E. Brigadier George Dash, who had been an officer in the Royal Army Medical Corps and examined soldiers who were blinded by gunshot wounds to their occipital lobes, observed that they were able to distinguish visual stimuli with specific characteristics when these appear in the patient's blind field. Team E, you have to answer what is his full name. Brigadier George Dash.
Redox.
That is the right answer. And what is the phenomenon called?
Redox phenomena.
Yes, it is the redox phenomenon where patients who are blind can see or can appreciate. They do not see it, they can appreciate moving objects in their blind field. You get 10 points. Team E gets 10 points. And this is the last question of the second round. That will go to Team D. T for Delta. Team D, here's a question. This is an organism, and you have to identify what is the claim to fame of this organism. Please, teams, note that your lip syncing can be seen by others of the teams on Zoom, so be careful. Team D. Which disease does? I want you to identify the disease that this organism causes. Commonly related to ophthalmology. You can repeat your answer if you want.
Aspergillosis.
Oh, this is not aspergillus. Team C.
The black fungus rice, the mucormycosis. Hello, sir,
Yes.
mucormycosis, black fungus.
Black fungus is a very colloquial term used by laymen.
Orbital mucormycosis.
That is the right answer. This is the organism that most commonly causes rhino-orbital or cerebral mucormycosis, and it is caused. The organism's name is Rhizopus or rhizae. Rhizopus is the most common organism that produces ROCM. So I think we have come to the end of 2 rounds, and I think the scorers, we can start tabulating the scores. And unfortunately, we'll be saying bye-bye to 2 teams this round. While we wait for the scorers, how did you find the quiz so far? Any of the teams can answer. Too easy, too tough? You can be frank so that I can modify the further questions so that it can be easier or tough. Of course, I'm joking. I cannot modify the question. Scorers, Dr. Farzana, Dr. Anju, Dr. Reshmi.
Yeah, so at the end of 2 rounds, we have the scores. At the top place, we have Team C, Kochi, with a score of 40. And the second place is a tie between Thrissur and Trivandrum, Team E and Team F, with a score of 20. Again, we have a tie between Kozhikode and Kottayam, Team A and Team B, which is points of 10. And Team D, Malappuram, they were yet to score. So really sorry, I think they'll be eliminated. Regarding Kozhikode and Kottayam, Team A and B, the quiz master will let you know.
So we have a tie in the very, very beginning. So it's a very interesting thing to happen. So we'll need a tiebreaker, and I'll have to stop sharing for that. Well played, Team Malappuram, and good luck next time. You can still remain on the quiz. Please don't answer any questions, but you can still remain, and you can hear the questions and answers. And between Team B and which is the other team?
Team A and Team B.
A and B.
Kozhikode and Kottayam.
A and B.
A and B. I will ask you a tiebreaker question. It is a sudden death question. Okay. So what I need you to take your second device, log into justbus.in. Go to the website justbus.in. And use the room code KOS quiz. KOSQUIZ. And name your teams also. Give your team name. It will be a buzzer question. And the team that answers will go through. If the team attempts and does not get it right, that team will be eliminated.
For the ease of the audience, maybe team A and team B can raise their hands. So it'll be easier to spot the teams. No, you can use the reactions and raise your hand.
I think they are more stressed with the getting into that room.
Yeah. A and B, I'm still waiting for you. You are not joined the room yet. It's KOS quiz. Put it in the chat box for you.
We have joined, sir.
I cannot see you on the. Can you do a buzzing just for a trial?
Buzz, sir.
Yes.
I cannot see you.
But we can hear the sound, I think. Is that sound the buzzer sound?
Are you sure you joined KOS quiz?
Yes, sir.
Can you join again?
Okay.
Recreated a room.
Sir, enter room.
Yes, I got Kozhikode now.
Hello.
I got Kozhikode alone. Team B, I do not have team B. Kottayam.
Kottayam.
Capital letter KOS is.
Can you get out and get in again? I still can't see you on the player board. Kozhikode, you can try your buzzer once. Yes, I can see you. I've got.
So capital KOS.
Small
letter
KOS.
Letters. All are small letters.
YouTube chat box la endeങ്കിലും ഉണ്ടോ നോക്കൂ.
Kottayam, you're still not in. Yes, team B. Team B is in. So you can buzz yourself, team B.
Yes, try.
Yes, I can see your buzzing. Okay, so the rules are simple. One question will be asked, and either of you can first buzz. Do not shout the answer out. I will ask you, only then answer it. Okay. You can buzz, and the first team to buzz will be asked to answer. If you get the answer right, you are through. If you don't, the other team gets through. So it's sudden death. Am I clear? So we'll go to the questions now. This is the first question. Teams ready?
You cannot see.
What is the mechanism of action of chloramphenicol? What is the mechanism of action of chloramphenicol? Still have no buzzers. Come on, one of you. Be brave. We are seriously lacking a bravery here. Are both of you giving up? Then we'll move on to the next question. Are both of you giving up, A and B?
Yes, sir.
B has not given up yet.
Sorry.
What time? Want to answer that? Please don't Google or ask anyone else. So no team has answered this. So we'll move on to the next question. And the answer is inhibition of 50S hour ribosomal subunit and inhibition of bacterial protein synthesis. Okay, the next question. We're going to the next question. Yes, wanted to ask something?
I know, sir, just connection, lost connection. Answer. Okay. Okay, sir. Okay.
First, then I'll ask you and then only answer. Remember, people can hear you. You have to buzz first. And I will ask you. I have not received any buzzers yet.
Sir, we have buzzer.
All right, Kozhikode.
Hi, sir. We have best see.
I have received Kozhikode's buzz. Give your answer.
Sir, 193.
193 what?
Nanometer.
Yes, that is the right answer, Kozhikode. So we have broken the deadlock finally. And Kozhikode is through. 193 nanometers is the right answer. And the rest of the tiebreakers I'm not showing, right?
Just a clarification, they gave the 10 points for this question, which will be added to the tally.
No.
Yes. No. This question does not.
This is a tiebreaker.
Tiebreaker. They do not get any marks for this. So, unfortunately, Team B Kottayam, you have been eliminated along with Malappuram. Very well played. Please do continue to remain and enjoy the quiz. And all the best next time. Next rounds, now that we have the teams that are going through, it will be, can the scorers tell me which teams have gone through?
Team A, Team C, Team E, and Team F.
A, C, E, and F. We'll continue the rest of the quiz with these 4 teams. Congratulations, teams A, C, E, and F. So, we go on to the next infinite bounce round. 10 points for the right answer, no negative marks. And we'll be moving from A to F. This round, A, C, E, and F, right? So, take your question. Published in 19.
Sir, voice.
Can you be louder, team A?
Your voice is, we can't see the screen.
Prashant, the question is not visible.
There is some network issue apparently.
Question is not visible to anyone?
Now it is.
Start the time from now. 1914, these were published. This was directly from that publication. What description? These are the first description of what procedure in ophthalmology. Procedure can be a diagnostic or therapeutic.
Sir, gonioscopy.
As a brilliant guess, how did you understand that is gonioscopy?
Yes.
The guess. Yes, quizzing is always about educated guesses, well guessed. So, who do you think described it? Described by Salzman. Okay, Salzman did it. So you get the 10 points. Team A gets 10 points. The gonioscopy, which is described by Salzman. Team C gets the next question. Am I correct? Team B and D have been eliminated. Sorry, B and E has been eliminated. Team C gets the next question. Name this instrument and its purpose, or its purpose. Anyone would do. There are clues within that photograph.
Sir, anterior capsulotomy.
What do you think? Anterior?
Capsulotomy, capsulorhexis.
Yeah, make up your mind.
Capsulotomy, sir.
Anterior capsulotomy.
Yes, sir.
I go to team D. If I get a better answer, I will give it to the team D. So team E. Team D has been eliminated. Team E.
The cystitome.
Okay.
It's a cystitome.
Yes. What would be its purpose?
For anterior capsulorhexis.
Can you be very specific? There is a clue in the picture which you can use.
Anterior capsular.
You have to be very specific. Go to team F.
Sir, cystitome, continuous curvilinear capsulorhexis.
That is the right answer. I will have to give the marks to team F. The word Howard Gimbel is quite clearly written there. What did Gimbel do? What is his claim to fame? There are many. One of his claims to fame is unmute yourself.
CCC, sir.
That is the continuous curvilinear capsulorhexis described by Gimbel. This is from one direct capture from one of his videos. One of the first capsulorhexis videos that he demonstrated. His system looked like that. So as you have guessed, this round has questions mostly from history of ophthalmology. Team F gets 10 points. Now the next question again goes to team A. Team A, this is your question. How is this device related to ophthalmology? Hope you can see the picture. Working device. How is this related to ophthalmology? Team A. Please be quick. Okay, the time is about up. What is it? I can only hear murmurs. I can't hear any answer.
Stereoscope. Hello.
Yes.
Stereoscope.
Stereoscope. Wonder what that is. That's not the right answer. Team C.
Sir, Sheen-Fluke principle.
That is brilliant. That is the right answer. What is this? What is this
On
instrument?
your topography. No, this is not topography, sir. This is a video camera that is used.
What camera is? What is peculiar about this camera?
You can change the focus, depth of focus.
Change the depth of focus.
Depth as in like you can change the focus.
Three planes.
Three planes. You can change the which plane?
You get the 10 marks. Don't worry.
So that
Aram se explain what you're trying to say.
There is a image plane. There is a focal plane, and there is a.
That is the textbook description. I want you to answer what is this peculiar about this camera? I asked this question because most people answer this question correctly in their exams, but they don't really understand what it is.
Anterior curvature and posterior curvature of cornea canopy.
No, really, what this camera does is a sheaf look camera. The normal cameras, the lens, the image plane, and the object plane, they have to be parallel. They're all parallel. So you cannot focus on an object which is curved. The whole object cannot be focused. Only one area can be focused. But in a Shimflu camera, you can tilt the lens and the image plane as you want. As you can see in the camera, you can tilt the lens plane and the image plane, so that all three planes intersect at one point. And this principle is used in Pentacam and other modern topographies. So you get 10 points, Team C. So the next question goes to Team E. Team E, ready?
Yes.
What is this the image of? Very big clues given in that question. Picture. I hope we can see the picture. This is the image of
Condensing.
thing.
Hello. Condensing lens.
Of what?
Ophthalmoscopes.
No, not the right answer. The next team F.
Condensing lens of operating microscope.
That is not the right answer. Team A. Not as difficult as you think it is. Quite a straightforward answer. Team A.
Slit lamp.
That team A who answered?
Slit lamp.
This is a slit lamp. You are saying this is a slit lamp.
Lens. Condensing lens of.
Condensing lens of a slit lamp. I wonder what that is again. That's not the right answer. Team C.
The contact lens, sir.
No, that is not a contact lens. All the teams have exhausted their chances. Can you make another wild guess? There's a company's name, Rainer in ophthalmology.
Sir, fake Indra.
No, you can see that box is very worn out and very old. So something very old. Something that happened in 1949.
1949.
If I had written another name, you would have immediately got answer.
IOL, sir.
Yes, this is the Ridley IOL, manufactured by Rainer. So nobody gets points for that. This is how it came. Right? So nobody gets points. I think it's Team F's question. Am I right, scorers? Please correct me if I'm wrong. Next question is back to Team F. Team F did not answer. This was a direct question to Team F, correct?
Question to E.
E. You were asked this question. Okay. Okay. So E gets the next question. Am I right, scorers?
Yes.
Anju? Yes. Yeah. Okay. Next question goes to Team E. Sorry, I'm sorry. The round is over. The round is over.
Fight!
The round is over. So the order reverses again. The question goes to Team F. 4 questions were asked because there are only 4 teams. There are no 6 questions, there are only 4 questions. The question goes to team F again. Please note the question is to team F. Same rules, no negative marks, 10 points for the right answer. So team F, this is your question. This is the picture of the eye of Miss Alberta Cassidy. About 11 days after she underwent a pioneering procedure in her eye on March 25th, 1988. That's about 2 days ago, it was the anniversary. She was ametropic prior to the procedure, and after this procedure, her refraction was plus 4.5D. Soon after this procedure, she underwent orbital eccentricity, and a few months later, she passed. What procedure did happen to you? You undergo this, and you end up being extremely hypermetropic, and then you undergo orbital acceleration, and then you die. On March 25th, 1988, this happened. What could this procedure be? Team F. Team F, you hear?
Silicon oil injections.
No, that is not the right answer. There are a lot of misleading things in this question. I'll tell you that. Team E, slightly misleading, but not untrue. Old events are true. Team E, any guesses? Team E? I think minutes past, the time should be a little shorter.
Pass.
Okay. Then next would be Team C.
Sir, local anesthesia induced retroorbital hemorrhage.
Team C.
Sir, local anesthesia, peribulbar, retrobulbar block induced retroorbital hemorrhage.
No, that is not the right answer. You said retrobulbar block induced hemorrhage. That is not the right answer. Team A. It's a very misleading question, I told you. You may take a guess.
Vitrectomy.
That is not the right answer. So all teams have failed to answer this. The right answer is examen laser PRK. Now, why would anyone undergo acceleration after PRK? It's not a complication of PRK. It is actually the hypermetropia was a sign of success of the PRK. The PRK was done on a patient with a Miss Cassidy had a end-stage orbital metastasis, orbital malignancy. So she was anyway slated to undergo orbital acceleration. So thus they used her to perform the first human PRK. That is Dr. Margaret MacDonald and Dr. Kleiss who did the first PRK. The target was, she was ametropic before the procedure. The target was plus 4.5 diopters, and it was achieved. The minus 4.5 diopter, that correction that was done with PRK. And after the acceleration, the specimen was sent to the lab to examine for changes that PRK induces. And after all these procedures, it got the FDA approval later on. And she passed away from the malignancy, so not from the procedure. That's why I told you the question was slightly misleading. Next question goes to Team E. This is your question, Team E. This thing was used by Ernst Custodes in 1949 to perform which procedure? It's written in some other language, but the first part is still English, polybiology. Custodes pioneered this procedure, which is quite commonly done nowadays. Team E. Take a guess or you can pass.
Conjunctival. Thanks.
Conjunctival?
Scraping.
I did not hear you.
Conjunctival. Smocular specimen collection.
No, that is not the right answer. Team C. Team C, you already have had time to think. You have to answer fast.
For corneal preservation.
No, that is not the right answer. Team A. Team A. Please answer quickly.
Pass.
Did you say pass?
Yes.
Team A has passed. Team F. Would you like to attempt?
Riboflavin, sir.
No, that is not the right answer. So all teams have failed to answer this. This is actually a scleral buckling. Polyviol implant was used to form scleral buckling. So nobody has got this answer right. So team E gets the question again. Team E. Was it team E? Scorers? It was team E, right?
Yes.
Yes.
So this is your question. Which gentleman invented this instrument? Instrument which is used commonly nowadays. The earliest form of this instrument.
Alvar Gulstrand.
And the instrument is?
Slit lamp.
Yes, that is the right answer. Team E gets 10 points. The slit lamp, earliest form of slit lamp invented by Alvar Gulstrand. Also incidentally won the Nobel Prize. Next question is going to team B, no, sorry, team C. Team C, the last question of the round. What is the major contribution of David Apple and Kensaku Miyake to ophthalmology?
Sir, Miyake-Apple view, the cadaveric view of cyclophotocoagulation.
Is it cyclophotocoagulation alone?
Cyclodestructive procedure.
I'll give it to you, but it's the cadaveric view of the posterior part of the section of the eye. It is mainly used. Yes, it can also be used in used to see the destruction of the ciliary body in cyclodestructive procedures. But more commonly, it is used to see the orientation of IOLs and how IOL sits in the back. It's known as the Miyake-Apple view. You're right. You're right. You get 10 points. It was described initially by Miyake and taken forward by David Apple and his lab. So we have come to the end of 2 rounds, and hope the scorers are ready with the
round 5.
And we'll have the scores later. You can have the scores later. We go to the next round, round 5. I call it the big picture round. Again, this round requires participants to be logged into the buzzer room. I would like to all of you to join the justbuzz.in room named KOS quiz. Okay, in this round, one part of a picture will become clear after each question, and any team can answer the picture question at any time. They can press the buzzer, and I will ask them to answer, and only then they should answer. But the 5 questions that will be asked only to one team. Those team that I'm asking them to. However, the big picture can be answering the big picture correctly, and -10 for answering it wrongly. Have you joined the room? I can't see any players.
Sir, room code.
KOS quiz again.
Small letter KOS quiz.
Small letter KOS quiz. No one has joined till now. Has anyone joined? And okay, Kozhikode, I can see Kozhikode now.
Sir, we have joined. Is it KOS space quiz or without space? Sir?
No, without space. It's just one continuous KOS. Team F has joined. Kozhikode has joined.
So we have also joined.
Small KOS QUIZ.
Yes, sir.
Team E has joined. I can't see Team C yet.
Suggested.
Just bus.in, join room. Small KOS QUIZ. I have 3 teams.
So can you
Still
see now?
Still no Team C. Can you buzz yourself?
Yes, sir.
All teams, press the buzzer.
We can see that.
All teams, press the buzzer.
Bus, sir.
But sir.
Bus, sir. Bus, sir.
Not yet showing up. We have a small delay. Still can't see Team C.
Sir, in ours it is showing team F and Kozhikode and all in our buzzer board.
Sir, now.
Can you all of you rejoin again once more? Join once more. Team E, F. E and F are joined.
Capital.
There's no caps, all are small. Team Cochin has joined now. Kozhikode. Now I can see all 4. Okay. Please buzz once. One trial buzzing. F, Cochin, E. I can't. Yeah, Kozhikode. All have all buzzing. I can see. Once more. Can you buzz once more? Okay. I can see all buzzers now. I hope I'm clear with the questions. I mean, first question will be to Team A, and Team A will receive 5 questions. All sub questions can only be answered by Team A. They cannot be answered by any other team. However, at any point, you can press the buzzer. Any team can press the buzzer. And if I see the buzzer here, ringing here, I will call that team out and they can answer the big picture question. If they answer it wrongly, they get -10. And you get, for any team that answers the big picture correctly at any time, you get 40 points for answering the big picture correctly. Am I clear? Any doubts? Okay, so we'll move to Team A now. Team A, for your first question. Temporal lobe lesions produce what kind of field effect? You have to be quick here. Only to Team A. Pie in the sky, that is the right answer. So you get 10 points. Team A gets 10 points. And this is one part of the big picture. Anybody wants to attempt, can attempt. Even if Team A wants to answer the big picture, they can press the buzzer and answer. Remember, +40, -10. Next question to Team A. The smallest and largest divisions of which nerve pass through the superior orbital fissure outside the common tendinous ring. Read the question carefully. The smallest and largest divisions of which nerve pass through the superior orbital fissure outside the common tendinous ring.
Smallest and largest division of which nerve?
Team A.
Trochlear.
That is not the right answer. Right answer is ophthalmic nerve. And which are the divisions, the nerves that pass outside the common tendinous ring? Lacrimal, frontal, and trochlear. And lacrimal and frontal are the smallest and the largest divisions of the ophthalmic nerve of division of trigeminal. That is the question. That's the second part of the picture. That's clear. Third question to team A again. High minus lenses produce dash distortion. What kind of distortion do high minus lenses produce? Me? Keep an eye on the big picture also. Team A, the time is coming out. There's no negative marks for this. You have to answer the next 5 seconds. Okay, you passed it. Barrel distortion. High plus lenses produce pincushion effect, and high minus lenses produce barrel distortion. So the next question again to team A. No one has buzzed yet.
Sir, we have buzzed.
Team E. Yes. Can you give the answer?
Morning glory.
Morning.
That is the right answer. 40 points to team E. Congratulations. You have guessed it correct. Team E gets 40 points. Please, chorus, please note. Now the big picture is out of the picture now, but other questions still are there. 40 points to team E. Please note, when there is a small delay in the buzzer, once you buzz, just shout it out on the screen, or not the answer. Say that you are buzzed. All teams, if you have buzzed, just say it on the screen, because there's a small delay in the buzzer appearing. Okay, next question to team A. Name a selective alpha-1 agonist commonly used in ophthalmology. Team A. That is? I cannot hear you. Epinephrine. Epinephrine is not the right answer. It is not a selective alpha-1 agonist. Phenylephrine. Phenylephrine is the right answer. And the last question is, accepting the null hypothesis when it is false is called team A.
Beta error.
No, there's nothing called a beta error, but there is something called the type 2 error. Be close. So this is the big picture which has already been answered by TV. So I think we'll move on to the next question. Team C gets the next question. Team C ready? Teams, I think you should, when after you buzz, please shout out on the screen also.
Sir, our buzzer is
Still yellow color.
our
Buzzer is
still in yellow color.
Showing bus.
Okay, now it's okay.
okay. Just shout out on the screen also. Okay, after you buzz. All right. Next question, Team C. The cortical center which controls saccades is
Frontal eye field,
more specific.
area number 8.
That's correct. I'll give you the points. Which side?
Contralateral.
Yes, that's the right answer. It's a contralateral frontal eye field, a Brodmann area 8, the first part of the big picture. Next question. Which structure is situated near the orbital apex between the lateral rectus and the optic nerve?
Ciliary ganglion, sir.
That is the right answer. 10 points again to you. To the next question.
Sir, we have bus.
How much
sir.
should a 4 diopter lens be decentered
have-
to produce
Sir,
C?
we
C
have
has
bus.
burst. Yeah, you can give your answer.
Sir, it is
C has come first.
retinoblastoma. We are seeing a rosette, sir. A retinoblastoma. Flexner intestina rosette.
That is absolutely correct. I don't know how you guessed it. It's a brilliant guess. Get 40 points. The flexner intestina rosette in histopathological specimen of retinoblastoma. Team C gets 40 points. And this is your next question. How much should a 4 diopter lens be decentered to produce good prism diopters of power?
0.5 millimeter decentration.
0.5 what?
Sir,
I didn't hear the 0.5. What is the unit?
millimeter, sir.
0.5 millimeters. That is the wrong answer. It is 5 millimeters, 0.5 centimeters. The next question. Drug of choice in MRSA infections.
Vancomycin, sir.
That is the right answer. 10 points again. Listen to this question carefully. A student wants to know the correlation between postoperative antechamber inflammation and the density of cataract. He or he uses the Sun classification of antechamber cells for the same. Now, what kind of variable is it? The statistics question.
Independent variable, sir.
I'm not looking for that. I'm not looking for an independent or independent variable. You only have one variable. What kind of variable is it? Another classification for variables. Get one more chance. Huh? Okay, I get it that I take it that you're not answering it. It is ordinal variable, and the picture, as you can see, beautiful flexner intestinal rosettes of retinoblastoma with an empty lumen. The next question goes to team E, the major question. Teams ready with their buzzers, and shout out also after the buzzer. Team E, lesion of the paramedian pontine reticular formation produces what ocular motility defect?
Ipsilateral adduction and contralateral abduction, called internuclear ophthalmoplegia.
That is not the right answer. It is not adduction and abduction that they affect. It is the loss of horizontal saccades and is the gaze palsy. It is not just an adduction or abduction. There are other phenomena also associated with PTRF. The next question to you. Which structure serves as an attachment for the check ligament of the lateral rectus muscle, the lateral palpebral ligament, suspensory ligament of Lockwood, and the levator palpebrae superioris muscle? Two structures.
Wittnall's tubercle.
That is the right answer. 10 points to you. The Whitnall's tubercle of Whitnall. Nobody has buzzed so far. Next question. What is the shape of the tear lens produced by a rigid contact lens with a base curve that is flatter than the anterior surface of the contact? Shape of a tear lens. Me? You have to answer the next 5 seconds.
Concave.
That is the correct answer. Good guess. Next question to you. Nobody has buzzed so far. Name the polymer of sodium glucuronate and acetyl glucosamine. Commonly used polymer nowadays.
Sodium hyaluronate.
That is the right answer. 10 points again. No buzzers so far. F.
Sir, we are buzzer.
Yes, team F.
Sir, it's a ISO-DRS, sir. With upshoot.
Can you expand? What is
Advanced
DRS?
retraction syndrome, sir.
That is the right answer. Brilliant answer by team F. Trivandrum is advanced retraction syndrome. And you get 40 points for that. I think there's one more question left to team E. Which statistic is the range of values that probably contains the true mean in the population? Range of values that probably contains the true mean in the population.
Mode.
No, that is not the right answer. It is usually mentioned along with the mean in brackets, 95% confidence interval. So this is the full picture of a ISO advanced retraction syndrome. It has already been answered. Now, direct question to team F. Ready?
Yes, sir.
Your first question. Seesaw nystagmus is caused most commonly by, what is the site of lesion? That is what I want.
Paracellar tumors.
That is a brilliant right answer. 10 points. Paracellar masses. Next question to you. Which is the largest branch of the ophthalmic artery?
Central retinal
Answer
artery.
quickly.
Central retinal artery.
That is the second largest branch. Largest branch is lacrimal artery. There are no points for you. Next question.
Sir,
Team E, yes. Team E. Give the answer.
neovascular glaucoma. Neovascular.
Yes, I'll give it to you. Team E, 40 points. It is actually a picture of neovascular glaucoma, the ectropion uvea and rubeosus iridis. 40 points to Team E. Brilliant answer that. Okay, Team F, your question. Sub-question: to refine the axis of a cylinder, where should the handle of the Jackson's cross cylinder be placed?
At 45 degrees to the proposed axis.
45 degrees to the proposed axis. That's not the right answer. The handle of the Jackson cylinder should be parallel to the axis of the cylinder in the triangle. They asked where the handle of the axis should be. No points. Next question. Name a second generation topical drug that acts by inhibiting topoisomerase and DNA gyrase. Second generation drug used topically that acts by inhibiting topoisomerase and DNA gyrase.
5-fluorouracil, sir.
My God, that's not such a difficult question. That's not the right answer. Either ciprofloxacin or ofloxacin. Few fluoroquinolones inhibit DNA gyrase and topoisomerase. Next question. In a normal distribution, what percentage of values lie outside the mean plus or minus 2 standard deviations? Read the question carefully. What percentage of values lie outside mean plus or minus 2 standard deviations?
5%.
That is the right answer. I was expecting you to go wrong 95%, but you tackled the googly quite well. That is the right answer. 10 points for you. That is the picture of the neovascular glaucoma, which team E has stolen. So with that, we come to, I think, the end of the round. So scorers, we busy calculating the scores. That time we'll move to round 6. So this again is a question, is a round of clues. If you answer the question without any clues, you get 40 points. If you answer with 1 clue, you get 30. With 2 clues, you get 20. And if 3 clues, you get 10. But there's no negative marks and you get only 1 chance. There's only a single chance for you to answer. So we'll start with team F this time, because we started with team A last time. All questions go to one team only. No other teams need not answer. Are we clear?
Each two will get 1 chance to answer.
No, it's just 1 chance in total. So you either answer and you get it, or you don't get it. You won't get another clue if you answer it wrongly. Okay, so team F. Your question. 21-year-old female with a history of migraine complains of sudden blurring of vision
We are
for
not
the
able to
past
see
2
the
days.
question, sir.
She has no history of wearing any glasses.
So we are not able to see the question.
There's no image
Yes,
of the question.
I'm sorry, the internet had malfunction. Can you see it now?
Yes, yes.
Yes, sir.
Okay, it's a 21-year-old female with a history of migraine with a sudden blurring of vision for the past 2 days. No history of wearing glasses before. The retinoscopy was as follows. And the best corrected vision was as follows. You have to give the diagnosis. That is the fundus picture and the OCT. Want, I can give you the first clue. You have to ask for it.
So next clue, sir.
Next clue. This is your next clue. Intraocular pressure with Goldman applanation tonometry is 26, both eyes. Remember, there's only one guess allowed. If you want, I can give you the next clue.
Next clue, sir.
Next clue. This is your next clue. Hope you can see the 2 pictures. $20 points.
Sir, choroidal effusion, sir.
More specific.
Probable cereochoroidal effusion due to if she's been taking topiramate for her migraine.
And what about the IOP? I'll give you the answer. I'll give you the points.
It will due to the secondary angle closure.
Yes, this is secondary angle closure, secondary to topiramate. That was the last clue. So you get 20 points. You answered in 2 clues. Team F gets 20 points. The topiramate induced secondary angle closure. Next question goes to team E. Team E, ready? Yes. Your question. A 70-year-old woman with unilateral redness, irritation for 1 year was treated with steroids, doxycycline, and lubricants several times, but the problem keeps on recurring, and it is unilateral. Get only one guess. If you want, I can give you one more clue. Only one guess. Remember that. Do you want a clue? Do you want a clue or did you answer? You want a clue?
Yes.
You want a clue? My internet slowed down a little. So you say, I'm guessing you said you wanted a clue.
Yes, sir.
Okay. Okay, this is your first clue. In examination, there was a hyperemic papillary hypertrophy of the entire upper alveolar conjunctiva with scattered deposits of white flaky material. So 30 points. What I can give you another clue.
Peripheral ulcerative keratitis.
Why would you guess that? Any reasons you guess that? Because I have not shown a picture of the cornea at all here. Sorry, that is the wrong answer. Any other teams want to attempt? You won't get any marks for it. If you want, you can attempt. Any other teams want to guess? No marks, but any other teams can guess. No negative marks also. No? No clue? Amy, you want to attempt? No marks for you, but if you want to attempt. No? An oil red or stained specimen.
Sebaceous cell carcinoma?
Yes, it's a sebaceous gland carcinoma. Whenever you get unilateral redness in an old person that is not responding to treatment, you should do a map biopsy. Okay, so nobody gets any points for this. The next is to Team C. Team C, ready?
Yes.
Your question. A 58-year-old male bodybuilder complains of painless blurring of vision both eyes for the past 1 week. And the best corrected vision is around CF 1 meter in both eyes. This is the fundus picture. Only one chance. Want a clue?
Yes, the next clue.
Next clue. This is the next clue. Probably guess what investigation that is. You want another clue? Or you want to answer? So 30 points. No?
The next clue, sir.
Next clue. This is the next clue. You want to attempt it? 20 points. Or you can get one more clue for 10 points. You're on mute now.
CSR with PED.
I'll give it to you. Can you be more specific? Also tell me why you guessed that answer.
There is a sensory neural. And there are inglot leaks that are seen in FFA.
Yes.
You can see a sensory neural detachment in the
Yes.
OCT with a small PED in the OCT.
And what is the OCT showing there? Something has been measured in the OCT.
Yes, sir. Thickness of the choriocapillaries.
The choroid thickness is? Normal choroidal thickness is what? 250 to 350 microns. It is greatly increased. So it is, the right answer is the multifocal CSR bilateral. And this was the last clue. That is after IVMP, the patient developed increase of the PED. So you can't think that this is a leakage and give an IV nasal prednisolone, but the FFA will give you a good clue regarding whether it's leakage or CSR. So you get 20 points. You get 20 points for answering on the second clue. The last question now to team A. Ready?
Yes, sir.
2-year-old child, parents noticed the deviation of eyes for the past 6 months. And deviation at near is 30% diopters and at distance is 18% diopters. Age, duration, deviation. Want a clue?
First clue, sir.
First clue, this was the retinoscopy. This is after everything, after distance and drug correction. Or do you want to take a guess or one more clue?
Yeah. Sir, infantile esotropia.
You've taken the plunge. I'm sorry, that is not the right answer. It's not infantile esotropia. Should have taken the next clues. Any other teams? No points to you.
Sir, accommodative
esotropia.
Not accommodative esotropia either.
Accommodative refractive esotropia.
It's an esotropia with high AC by ear ratio. Okay. Sorry, I'll give you to, if you said accommodative esotropia, I would have given it to you. Kind of accommodative esotropia. The last clue, the high AC by ratio. Esotropia with high AC by ratio was the right answer, not infantile esotropia. Nobody gets points for that. And I think it's time for scores before we move into the final round. And I think it's time we engage the audience a little bit. By the time the scorers calculate the answers, the audience can type into the YouTube chat box. Dr. Bindu or someone who is looking at the YouTube chat box can announce the winners of the audience round also.
Better viewers.
Shall we go to the audience questions then?
Yes, yes.
Fight. Final round. Fight.
Scores are ready.
Scores are ready. Okay, I'll quickly go through the audience round. Right, we'll have the audience round later. I think we'll have the rapid fire and then we'll have
the that will
audience
be
round.
Yeah.
Yeah, you can announce the scores.
Okay, so Team E, Team C, Kochi is in the lead with 150 points. Very close behind is Team E, Thrissur with 140 points. And not so far behind, Team F, Trivandrum with 110 points. And Team A has to catch up, Kozhikode with 30 points.
So it is quite a close affair. The whole thing can go upside down in the last round. The last round is
Fight. Final round. Fight.
It is a rapid fire round, and please don't answer the questions on the screen. I would like you to log into the Google form link that has been sent already. If not, I'll send it again to the WhatsApp group. And please join the group. Please join, enter into that, and you'll start. As I start asking questions, fill the form. Don't vocalize the answers.
Sir, one doubt, sir.
Yes.
We have to submit the answers after each question, or
Yes,
like
you have to write the answers after each question, and finally you have to press submit. Only
last, no, sir.
Submit at the end. After you answer all 10 questions, you have to press submit, and then the form will be uploaded. You have the opportunity to change answers in between also, but I will not be going back and repeating questions.
Do we have a timer for this?
We can keep 30 seconds for each question. $30 seconds for each question. Okay. Because everybody will be getting the same amount of time, whatever time it is. Are you all right? All of you ready with your Google Forms? All of you ready?
Yes. Sir, one more doubt, sir.
Yes.
Sir, is there any time for, like, you have to, if the person who submits the answer first will be evaluated?
No. There is no nothing like that. There is no for fastest fingers first or anything. But you have to complete all the answers and press submit before the end of, before I say end. All the 10 questions. Okay. Hope I'm clear. So we'll go to the rapid fire round. All of you are ready with your pads or iPads or mobile phones. So I'm going to the rapid fire round now. Ready? Chorus ready? Okay, here we go.
Yes.
The first question. Minus 1.25 diopter sphere and plus 1 diopter cylinder at x degrees is an example of what? What kind of refractive error? I'll give you time to type now. For that, I will move on to the next question. Okay, this is the next question. Look carefully at this photograph and name this procedure. The named procedure, you have to name it. Question number 2. Give you time to type out your answer. And I'm moving to question number 3. Identify this. You have to be very specific with your answer. Not a general answer. Can move on to the next question. Which is the stain that is used in histopathological specimens to identify lattice corneal dystrophy? Stain specific for lattice corneal dystrophy. The time to type now. Moving on to the next question. The A wave in ERG is produced by what? A wave in ERG is produced by Time for you to type the answers. Right? I think it's time to move to the next question. The ratio of ganglion cells to cones at fovea is? Ratio of ganglion cells to the cones at the fovea is? The time to type. That's it. Next question. Greater wing of sphenoid is part of lateral orbital wall. True or false? Question number 7. Greater wing of sphenoid is part of the lateral orbital wall. True or false? Let's type the answer now. Next question. 8. The most common intraocular malignancy in adults is? Most common intraocular malignancy in adults is? Time to type. Question number 9, penultimate question. ETDRS study concluded that PRP reduced the risk of severe vision loss by at least 50% as compared to untreated control eyes in eyes with PDR. True or false? The ETDRS study concluded that PRP reduced the risk of severe vision loss by at least 50% as compared to untreated control eyes in eyes with PDR. True or false? I think you had enough time to type your answer for question number 9. Next question, and the last question is this. Question number 10. Name the slit lamp illumination technique that utilizes the principle of total internal reflection. Name the slit lamp illumination technique that utilizes the principle of total internal reflection. You have to type in the answer now and press submit. Please press submit within the next 20 seconds.
Sir, we submitted, sir. Did you get it?
That's okay. We'll record your answers. See, Cochin and Kozhikode have submitted. The other two teams, yes, F has also submitted. And time is about to run out. And your time is up. All right. I think scorers can calculate the tally the answers now and calculate the scores. Each correct answer gives 10 points.
Chat box answers.
So the answers, the example of mixed astigmatism. As you can see, the plus value is slightly. Sorry, it's not an answer of example of mixed astigmatism. This is the wrong key that has been submitted here. It's a compound myopic astigmatism. Scorers, please note the key has been submitted wrongly. It is not mixed astigmatism. The compound myopic astigmatism. That is the right answer. Hope scorers have heard it. Farzana, the wrong key that has been submitted.
Yes, yes.
Yeah, it's
Yes,
compound
please
myopic. Noted. Yeah, compound myopic astigmatism is the right answer. This is the Hughes procedure used for repairing defects of the lower lid of more than 50% length. This is a type 1, Boston type 1 keratoprosthesis. And if someone has not mentioned type 1 keratoprosthesis, I think you can give them 5 marks instead of 10. You have to mention type 1. The stain used in histopathological specimens to identify lattice corneal dystrophy is Congo red. The A wave in ERG is produced by photoreceptors The ratio of ganglion cells to cones at fovea is 1:1. The greater wing of sphenoid is part of the lateral orbital wall. It is true. The right answer. The most common intraocular malignancy in adults is choroidal metastasis. Not primary intraocular malignancy would be choroidal melanoma, but overall common intraocular malignancy is choroidal metastasis. CPDRS did not say that. It was said by DRS. So the answer is false. The slit lamp illumination technique that utilizes the principle of total internal reflection is sclerotic scatter. You know your slit lamp illumination technique, you will know the answer. While the scorers are calculating the scores, the final scores, I would request the scorers to announce from the bottom up. Keep the tension high. Meanwhile, we'll go to the audience questions. Audience can type the answer in the YouTube chat box. Bindu ma'am, can we go ahead with the audience?
Yes, yes.
Okay. Here we go.
I think we will just wait for some time because the
Yes.
YouTube.
There is a lag. Yes, I know that. The first question. What is the connection of Dr. Benedict Risuti to ophthalmology in Kerala? Interesting question. Dr. Benedict Risuti of keratoconus fame, Risuti sign. He was connected with ophthalmology in Kerala in one particular way. What is that? You can type it in the YouTube chat box. Anybody got the answer yet?
No response.
No response yet. Again, no negative marks to the audience polls. Teams, do you want to answer this?
Inauguration of
Inaugurated
Inauguration of
KSOS.
KSOS when? When was KSOS inaugurated?
1970.
1970? Oh, 1 year behind. Almost 1975. Because it was nearly the end of 1974. I'll come to the next question. Which ocular condition is related to this plant? It's for the audience. Question is for the audience. Which ocular condition is related to this particular plant? That's true. I think we'll take the responses at the end after all the questions are asked so that people get time to answer. What is palinopsia? Palinopsia is a term. What does that mean? Ophthalmological term.
Epidemic dropsy is one response received.
Okay.
Faisa Ibrahim.
That is not the right answer anyway.
Another response. And the answer.
Commonly, not so uncommon, that condition caused by the plants.
There's one more response. Madar juice keratitis by Aparna.
Is that correct? I do not know. Madar, the same plant. The response I was looking for is slightly different. Anyway, we'll see. What is the utility of cycloplegics in a patient with an uncomplicated corneal epithelial defect? One common misconception among many ophthalmologists in Kerala.
Palinopsia, I think visual hallucination is one response.
It's a visual hallucination, but I would like to know more about it. What it means.
After image.
That is more of a correct answer. Yes.
Anu.
It's not the name of who was answered.
Gitu Gopakumar is written after image.
Gitu Gopakumar has got it right.
Congratulations, Gitu.
Congratulations, Gitu. The next question is the cycloplegic's role in uncomplicated corneal epithelial defect. And coming to the last question. Okay, I think we come to the last question. That is the last question. Sorry, there are 4 questions. Anybody has given the response to that? Cycloplegics. You can ask the postgraduates.
This one is calotropis and chemical injury is been
That
given.
is the right answer. It's not a chemical injury as such.
Calotropis.
Calotropis is the right answer.
Jalaxri.
No, it was first answered by Aparna, calotropis.
Yeah, Aparna KS has also answered calotropis.
Calotropis. Okay, so Aparna KS, congratulations. Again, the last question, has anybody answered? Benedict Rizzuti has already been answered by our postgraduates. Any ocular condition related to plant calotropis has been answered. Palinopsia is after image or the persistence of image time. And the last question, that is the answer that we are waiting for. Why should you or should you not give cycloplegics in a patient with an uncomplicated corneal epithelial defect? I thought I'll get a lot of answers for this. Nobody's answered. Again, coming to the history of the first question, 22nd December 1974 was when KSOS was inaugurated by him, Benedict Rizzuti, in Ernakulam. This was Dwarka Hotel. Even in the history of KSOS on our website, ksos.in. And this is the calotropis that can produce toxic keratopathy. I don't know if Madar juice is the same. Is it? I have no idea. Find that out. Palinopsia is abnormal persistence or recurrence of an image in time. And has anybody answered the last one?
No, not yet.
Not yet. I think we'll go ahead with the answer. Are the scorers ready? Scorers, are you ready with the scores?
Not yet. We are just cross-checking.
Okay. Just mind you, the first question, answer to the first question in the rapid fire was compound myopic astigmatism. It's not mixed astigmatism as given in the key wrongly.
Rehana has answered keratoconjunctivitis.
For the last question. Why would you want to give a cycloplegic in keratoconjunctivitis? Well, the answer shouldn't be controversial, but unfortunately, it is kind of controversial. The answer is none. There is no utility for any cycloplegic in an uncomplicated corneal epithelial defect. The pain in a corneal epithelial defect is due to exposed corneal nerves, and it is not due to cyclospasm. And there is no point giving a cycloplegic in a patient with a corneal epithelial defect. That is the point I was trying to make, even though nowadays.
Yeah, there is a response, usually not given.
Okay. Who's that? Give them.
Geetu Gopakumar.
Again, Geetu gets the points for that. Geetu will be getting a 5-star from me personally in the next conference.
She's got 2 responses correct.
Correct. Yes. So with the scorers, whatever scorers, I've run out of audience questions.
We'll ask the team how was the questions.
Yes. Yes.
How was the questions?
Yes. Teams.
Was it too tough?
Team. We'll start with Team A. Team A, how do you find it? Very good.
Bit tough, sir. We pressed the buzzer, but just after the other first and second.
Okay, you just missed out on the buzzer. Other than that, standard was too tough.
Tough.
Okay.
They were
Thank you
looking
for being honest.
Dr. Prashob's question, and they were surprised with all the new questions. I think that is.
Team B. Team B, how did you find it? Even though they were tough, I hope they're equally tough for all. Team B.
Yeah.
Team B has logged out. Kottayam. Team B is still here? Yeah.
Yes.
Was it too tough? Did you enjoy the quiz? Most important.
Yes, sir.
Enjoyed it. Glad to hear that. Team C. Kochi.
It was okay, sir.
It was interesting.
Interesting, sir, really. Like some
Okay,
questions.
it was just okay.
No, it's interesting.
Again, honest answers always come first. I like that. Thank you. Team D. What about Team D? He has logged out. Malappuram?
So it was a very good experience. I felt the second session was easier than the first session, unfortunately for us.
Okay, so the first two rounds were tough, so we were eliminated. And had you come into the second round, you would have answered more. Probably, yes. Probably. But then the way things are, sometimes luck favors you, sometimes it doesn't. But don't get disheartened. Please continue to participate in quizzes. And I'm sure you'll get better with time. You are all first year residents or which year?
Second year, sir.
Second years. Team E.
So it was a really good experience and a journey from the past to present. We really enjoyed, sir.
Thank you. Glad to know that you enjoyed it. Team F, Trivandrum.
Sir, it was a very interesting experience, sir. And as for the half of it was okay. As like the other team said, the first half was more difficult than the second half. So.
Half was more tough. I'll keep that in mind. Hope it was equally tough for everyone and pretty easy in the second half. Keep that in mind for the next quiz. Thank you for the responses, the honest responses.
But it was easy conduct. Everyone were familiar, like you seasoned them, so they were all familiar with all the proceedings. Like,
the procedures did get a little complicated, but then what is the fun if you don't have it complicated? If it's a straightforward quiz, there's no fun in it. So fun part is, I think, the most important part.
But then it went on smoothly. There was no delay much.
Yes, thankfully, there were not much of a
delay.
That was what I was worried about. Hopefully, next time we'll have a live person quiz. Much more interesting. Yes, ma'am.
Hello, Prashok. I'm not a PG. I've not been asked, but I liked all your questions. I enjoyed every minute of it. And a lot of it was, from my time as well. So thank you so much. I really liked your questioning. And
thank you, ma'am. Thank you for the call. I wanted everyone to be involved, not just the PGs. The audience should also be involved. We have people from all ages in the audience.
Yeah, that's true. The calotropis especially, we used to see such a lot of it at one time. The children playing with it with the milk, pale. They used to drop it into bottles.
Known as milkweed also. Pretty common. I mean, it's pretty common even nowadays.
I've seen a lot.
Are the scorers need more time?
Yes, sir. The score is ready.
Scorers are ready. Okay. I think you can.
The final score is.
You can come on. The video can please put on your video.
Yeah. Okay, sir. Okay, the first place goes to.
Can you start from the bottom, please?
Dr. Prashok, can you stop share? Can you stop share?
Yeah, I stop sharing.
Okay, so the carriers quiz, the final results are. The last place goes to Team A, that is Kozhikode, with 115 points. The third place goes to Team F, Trivandrum, with 175 points. Second place goes to Team E,
Trishur with 205 points. And the first place goes to Team C, Cochin with 215 points. Congrats to the winners.
Congratulations, Team COC. Congratulations, the second place team. Who was the second place? Trishur? Taco?
Yes.
Congratulations, Taco. Congratulations, TOC. Trivandrum is third, I guess.
Yes.
Kozhikode also very well played. You are not too far behind. I think you played really well. And all the teams were very good. I found were of very good standard. And they've done their homework well. And I hope all of you took the quiz in the spirit of the quiz. You should enjoy it more. Participating in the quiz must be more of an enjoyment than trouble for your attention. It should be fun. That is my whole point. Because I have been an avid quizzer from a long time, I would like to popularize quizzing. And I think more people should come forward and participate in quizzes. I thank KOS for giving me this opportunity to hold this quiz. Thank Bindu ma'am, Padmaja, Dahlia, Dr. Dahlia, Anju, Reshmi, Farzana, all the team. The whole. I'm sorry if I missed out anyone. Complete team of KOS for helping me in conducting the quiz. Yeah, ma'am. For comments from your side.
Thank you, Prasho, for that exciting and interesting. It was a twister, turner with nail biting finish. I think after third round and fourth round, everything started changing. It was participated well, even by the audience. We had some responses there too. Thank you very much, Prasho. Thank you for conducting it so well. Thank you, participants, all the participants. Thank you, scorers. Thank you. I think we now come to the end of the program. Yeah.
They did a great job.
The scorers, yeah. I think even they had a difficult time. It was all different. Thank you, Anju. Thank you, Reshmi, and thank you, Farzana, for doing that job. I think now we come to the end of the session. Thank you all for taking so much of pain, join. And thank you, audience, also for joining in. Thank you.
Again?
Yeah, Padmaja madam.
Can stop.
Yeah.
Stop streaming that.